A quick introduction. Global child and mortality decreased considerably over the last 30 years. Massive progress was made. However, there are large regional differences, and child mortality still remains very high, especially in countries exposed to conflicts and humanitarian crisis. Just as an example, Sierra Leone, a country in West Africa, faced a civil war in the 1990s and the Ebola virus epidemic between 2014 and 16. Sierra Leone made a lot of progress in reducing under 5 mortality, but child mortality under 5 still remains at 100 per thousand. Causes of child mortality in children under 5, you all know. More than 40% of children who die before the age of 5 years are newborns. In this session, we will not focus on newborn care. This is, from a nutritional point of view, quite specific, very important, but this will be addressed elsewhere. Causes of mortality are severe infections, respiratory infections, diarrheal diseases, and others. Sepsis. Severe infections can progress to multi. Of these children die of a sepsis syndrome. And importantly, around 45% of deaths in this age group are associated with malnutrition. Severe acute malnutrition, moderate acute malnutrition. So nutrition is an important element in essential pediatric critical care and needs to address nutrition of critically ill children with and without acute malnutrition. Important child health programs need to include children above 5 years. This is important for big donors around the world, not to stop at 5 years. So causes of mortality in these age groups, again, severe infections, but also trauma, road traffic accidents, exposure to violence and conflict. Non-communicable diseases play a role, environmental factors, and important in adolescent health and young adults, we need to cover and link also with maternal and reproductive health. So nutritional guidelines should include this age group. Newborn health and child health can only really be improved if we also link with maternal health. And importantly, young mothers carry a particularly high risk of pregnancy and delivery-related complications. Most of them are preventable, but also critical care of pregnant mothers is an important element to consider as part of essential PEDS critical care. HIV and tuberculosis. Globally, there are still high numbers of new HIV infections. Olana from Madagascar, who will mention this in her presentation, highlighting that reliable financial processes remain important for HIV prevention and treatment programs, including prevention of mother-to-child transmission. And HIV-TB, certainly an important differential diagnosis in the treatment process of critically ill children. Children living in conflict zones. More than 1 in 6 children globally now live in areas affected by conflict. Children and adolescents suffer from direct and indirect effects, and therefore trauma care and blast injuries needs to be part of essential pediatric emergency and critical care and nutritional guidelines. And overall, attacks on children need to be stopped. Displaced populations and vulnerable populations face particular challenges. And during humanitarian crisis, access to essential health services should be maintained. Needs of children, newborns and pregnant women is important during health emergencies, and WHO describes minimal standards for emergency medical teams. And here, the care of children, adolescents and pregnant women needs to be strengthened. An example is the response to epidemics like filovirus infections. Currently, a Sudan Ebola virus outbreak ongoing in Uganda. Climate change and health, important topic. And it will also have an impact on and therefore food security. And children in many low-resource contexts face particular challenges. Populations who historically contributed relatively minimal to CO2 emissions. So climate change will affect health or is already affecting health, and we need to consider climate change adaptation measures, and that includes also aspects of agriculture and food security. So as a summary, nutrition and the health of children is determined by multiple factors, but access to essential pediatric emergency and critical care services and free access is a crucial element of a universal healthcare coverage. Nutrition is an important element of essential critical care. And the purpose of this workshop is describe the scope of the WHO guidelines, experience from different parts of the world in terms of nutrition of critically ill children, including guidelines from high-resource contexts. And well, the question is there a gap? Is there a gap we could fill potentially by working on guideline development for critically ill children treated in low-resource contexts? Newborn nutrition guidelines are quite specific, but these guidelines should cover children under 5. It should include children with and without malnutrition. It needs to include children above 5 years and adolescents. And it should also include children with surgical conditions, trauma, burns. Okay, so this as a quick introduction. I will now hand over to Aaron, who will give a better or more detailed overview of the global burden of disease linked to critical illness and malnutrition. So over to you, Aaron. I would like to introduce Aaron Bansal. Aaron is a professor in pediatric critical care at a large hospital in Chandigarh, India, northern India, and he published in several journals and is also very active in the World Federation of Pediatric Intensive Care Society.
Thank you so much, Lorenzo, and thank you, Hans and Cynthia, for this opportunity to speak on this important topic of nutrition and malnutrition in critically ill children. And this talk has been prepared in collaboration and help from Dr. Mohammed Chisti from Bangladesh. So I thank him too for this. So I'm just speaking what we have made this together. So I will be speaking on the global burden of disease and related to critical illness and malnutrition. So this would be the outline for the next 10 minutes. I'd highlight the global burden, then what are the factors affecting the malnutrition, including the stunting, wasting, and overweight, and then specifically focusing on critically ill children. So this is the slide from the UNICEF which I've taken. So these are the important information about the number of children who are stunted, who are wasted, and who are overweight. So if you can see that stunting affects almost 22% of the children under 5 globally, and wasting occurs in almost 7% of the children under 5 as per the 2022 estimate. And now overweight is also a significant problem and is leading to a lot of comorbidities. So what is the trend of malnutrition which is happening from year to 2000 till 2022? So the yellow line represents the stunting, the red line is the wasting, and the blue line is the overweight. So it has significantly come down over the last 20 years. If you can see, the stunting has come down from 33 to 22%, but not so much improvement in the wasting. And in fact, obesity or overweight has started increasing because of our lifestyle. So the left side table is in the percentages and right side is in the numbers. So what are the various factors which affect the malnutrition? So the main areas which are affected for stunting, you will see that 9 out of 10 children are affected by stunting from these 3 main regions. That is the South Asia, the Sub-Saharan Africa, and East Asia and the Pacific. So they contribute almost 90% of the children with stunting. And similarly, this South Asia, Sub-Saharan Africa, East Asia, and Pacific also contribute more than 10, almost 9 out of 10 children for wasting. So these 3 main geographical areas are the main ones which contribute to malnutrition. If we divide it into the income-wise, the low income and the lower middle income are the main ones which contribute to the countries which contribute to both the stunting and the wasting. So there in lower income and lower middle income, it is as high as up to 33% and 28%, though significantly down from the previous one. It has come down, and it's significantly wasting and stunting is less common in the high income countries. But the drawback in that is that they have now increasing the obesity is increasing in the high income countries. And this is again in the stunting and overweight based on the low middle income countries. They contribute almost significantly in stunting and wasting in these low middle income and low income countries. So again in this, if you will see that the lower middle income countries contribute 51% of the children with malnutrition, 64% are due to stunting, 76% contribution is for wasting, and 42% in the overweight categories in these low middle income group of countries. So if we have to see what is stunting, basically it is a child who is too short for his or her age. And why it is important? Because it can cause significant irreversible physical and cognitive damage. And this effect can last not only in his or her lifetime, but can also affect the future generations. And this is the prevalence based on the country-wise. And you can see that the highest prevalence is in the African sub-Saharan region, and in the Asian or the South Asian region, and also in this Indonesia and Malaysia and these part of the world. And this is for the stunting again, how it has changed from 2012 to 2022. If you'll see that it has not significantly, but it is decreasing, definitely decreasing. But still a lot of work needs to be done in both the stunting and the wasting. So coming to wasting, it is basically too thin for his or her weight, and it can be due to rapid weight loss due to recent acute illness or the failure to gain weight, and the wasting can lead to significant increased risk of death. Again, the red and the brown chart represent the countries or the geographical areas where it is most common. And as you can appreciate, it is mainly the South Asia and the African sub-Saharan countries where it is more common. And again, in the South Asia, sub-Saharan are the global burden lies in this part of the world, which is contributing to wasting. And the other important, sometimes most countries are the double hit, that is they are both the underweight and the overweight. And overweight children can also lead to a lot of problems in the acute care management. And this overweight occurs because of the increased energy intake that exceeds your normal energy requirement. And this can lead to a lot of non-communicable diseases later in life. And not surprisingly, this is more common, if you can see, is more in the developed countries, like in the Australian region, though we have some in the African areas also. But you will see it is more in the North American countries, and the South American countries also have more obese population, which is increasing. And this is the increase which is happening from 2012 to 2022. So the number of obese are increasing worldwide. So this is just a fishbone type of diagram, and the upper one is about the obese, which is gradually increasing. Malnutrition, the lower blue one is about the malnutrition, though it is coming down, but we need a lot of work to be done. And these are the global targets of 2025 by the UNICEF and World Health Organization, and 2020 that we have to decrease stunting by 50%, wasting by 3%, and overweight children should not be more than 3%. And we have to maintain this at this level. So these are the targets for those. What about the malnutrition in critically ill? How common it is and why it is important? Because it can have some negative health consequences, lead to developmental delay. And we are more concerned about increased susceptibility to infections, neurocognitive problems, increase hospital and ICU stay, and increase mortality. All these can increase in that. So this was a systematic review of the malnutrition in various countries. So there are around 15 studies are included. And if you will see, these two are almost as high as malnutrition in ICU is common in almost as high as 81% or 83%. So these are the studies from Ethiopia. And this is the top one is from India. It is showing up to 51%. And the countries like the developed countries have incidence of malnutrition in ICU somewhere between 13% or 15%. So the average is somewhere between 30 to 40% is the worldwide average. So if we divide it into based on the income level of the countries, so in the low income countries, the prevalence is almost as high as 83%, and middle level income, it is about 38%, and high income countries, it is almost 30% prevalence of malnutrition in critically ill children is there. This is the study which we did in our ICU, and we studied the critically ill children with severe sepsis, and we measured their energy balance and energy needs using indirect calorimetry. And we found that from day 1 to day 7, they were energy deficient. And they were energy deficient to as high, and from starting on day 1 to almost 600 calories as the median, to going down to 300 calories by the day 7. And they also have a negative nitrogen balance in the first 5 days of the illness. So this is again an important data to suggest that malnutrition does occur in all children because of the energy deficit in critically ill children. This and another study from India, from New Delhi, which has shown that the mortality, though in severely malnourished children, the mortality is high, the ventilation needs or the duration is higher. They have a prolonged PICU stay and they have a prolonged ventilation duration also. So in moderately to severely ill children, especially severely malnourished children, these increases significantly in critically ill children. So thank you so much.
And we will quickly discuss some key elements related to essential pediatric emergency and critical care in the care of children with and without severe acute malnutrition. Oops. I hope the slides are moving. Sorry, little technical problem. So can you see the slides?
Yes, Hans, perfect.
So if we talk about essential pediatric critical care, we can define standards of care, minimal standards of care. WHO guidelines helps us in this context, but is leaving some gaps. So therefore, the input of international professional societies and national professional societies is important. Importantly, essential critical care provided in high and low resource contexts follows the same strategies and principles, but needs to be adapted to contexts. We have a little example. Mariam is 3 years. She lives in a country in the Sahel region and is sick since 3 days. She has fever, became increasingly lethargic, and has watery stools. She had a convulsion this morning. The mother rushes to hospital. This can be difficult in different parts around the world. Here are some pictures from Madagascar. So access to health facilities may be tricky because of geographical conditions, but also cost of transport. So it can be difficult in rural settings, but it can also be difficult in urban settings. Here pictures from Freetown. There may be limited public transport systems. There is cost for transport, and there may be crowded roads and other factors making it difficult to get from one place to the other. Our child arrives in a health facility, in a district hospital. She has a partially obstructed airway, some secretions. She's breathing fast and has some subcostal recessions. She has signs of shock, is pale. There's no dehydration. She responds to pain. She's febrile, and somebody did a mid-upper arm circumference, and it's 114 millimeters, meaning per definition, she has severe acute malnutrition. Just to highlight, if her MUAC would be 116, so a bit higher, but principally the same nutritional status, she would receive a different care package, especially it comes to fluid management and nutritional support. So health facilities should have triage area, and we can use WHO triage tools. Very simple, 3 categories, but very helpful. And WHO describes a structured approach to a critically ill, as we do also in high resource contexts. Airway, breathing, circulation, treatment of and so forth. And the adequate equipment needs to be available. We can define minimal standards of care, intermediate levels, and more advanced if you want level 3 care. If we come to respiratory support in a child with respiratory distress in hemodynamic instability, WHO defines SpO2 targets which we should achieve should be around 94%. Evidence of this may be limited, however, a useful approach. In case of persisting respiratory distress and hypoxemia, on a district regional hospital level, one could use bubble CPAP or high-flow nasal cannula oxygen. This sounds simple, but it needs to be well prepared and it needs a multidisciplinary approach. More complex, non-invasive respiratory support or ventilation and mechanical ventilation needs adequate resources and expertise and should only be done if that level of care is prepared and provided. If we come to oxygen, oxygen is defined as an essential medication by WHO. However, in many low-resource contexts, in many health facilities, there is no reliable oxygen supply. Any form of decentralized oxygen provision needs reliable electricity sources. A large number of health facilities, for example in sub-Saharan Africa, do not have reliable electricity supply, showing, just as an example, that implementation of essential critical care needs medical training, needs supplies, but also needs more complex hospital logistics and administration measures. An example, renewable energy can be useful, solar systems to provide electricity for O2 concentrators, but also for other biomedical equipment, cold chain equipment, and so forth. This is technically reliable and cost effective. The respiratory system of our child is stabilized, but she has signs of shock and she looks pale. The HB is 5.9. So if we assess shock according to WHO, the definition of shock is the presence of weak peripheral pulses, delayed capillary refill time, and cold extremities, a temperature gradient. For the care of this child, we need to know if the child has severe anemia, if the child has severe dehydration, and if it's severely malnourished. That will determine our fluid management. So we don't want to go too much into detail. Treatment of shock, in a way, is straightforward, but we need to stabilize airway and breathing, and we need to be careful with fluid administration, especially if the child has signs of severe anemia. Then, according to WHO guidelines, we should not give pre-transfusion boluses, just start maintenance fluids. We need to be particularly careful with fluid overload in children with severe acute malnutrition, respiratory and neurological emergencies. So, quick assessment of nutritional status can be done in an emergency department. Weight for height or weight for length will take a bit more time, but a mid-upper arm circumference or perimetre brachial can be done quickly. Alison will talk a bit more about the definitions of severe acute malnutrition and also the new use of MUAC in children under 6 months. Important, according to the child with severe dehydration and no malnutrition will receive a certain fluid management. In children with severe acute malnutrition, we are more careful. Which fluids to use? It should be it should be crystalloids and isotonic, ideally electrolyte balanced. There is no evidence that colloid fluids are of any benefits. So we use crystalloid isotonic fluids. If it comes to blood transfusions, at least on the level of a district hospital, we need to have a reliable blood bank. Especially in malaria endemic regions, we will see many children with severe anemia. WHO suggests different volumes of transfusion for the child with severe acute malnutrition and children without acute malnutrition. The evidence of this may be limited, and Médecins Sans Frontières, for example, decided to give the same volumes slowly for malnourished and non-malnourished children. Blood transfusion target in the sick children of 6 may be okay for some, but maybe too low for others. So this could be another important future research question. We need to review children carefully, monitor them. So monitoring is important, and point-of-care ultrasound can help us in some settings in the right hands to guide fluid management. The use of inotropes and vasopressors may not be a priority in all of the district hospitals and should only be done and used if we have the right resources and expertise. Our child is improving, receives a blood transfusion, but is hypoglycemic and has seizures. So blood sugar can be corrected, and new ETAT guidelines tell us to give 3 mL per kilo of dextrose 10%. A further example of management of neuro emergencies, we follow international status epilepticus guidelines with benzodiazepines as first-line treatment, and maybe as second-line anti-seizure medication we may use or benefit from the use of levetiracetam in the future. Acute kidney injury is a common complications in acute illness or critical illness and often neglected in the care of children. So an important element to look at, and also non-invasive interventions can have a good positive impact. There's a lot of work done by one of our colleagues, Minyo McCulloch from South Africa, around management of AKI and start of peritoneal dialysis in low-resource contexts. Sepsis. So this child has multi-organ dysfunction, has a severe infection, so we need to stabilize vital organ functions. and start adequate antibiotics as quickly as possible. Should check if there are any other infectious sources. In malaria endemic areas, we need to consider treatment of malaria. And Kirili will talk a bit more about challenges in antimicrobial therapy in children with severe acute malnutrition, and especially also in children with edema and skin lesions. HIV needs to be considered in the critically ill as a comorbidity, especially in the severe acute malnourished. And we also need to think about non-communicable diseases. Our child is improving, but still comatose, has a bit of abdominal distension and considerable gastric aspirates. So we, in this case, can't start enteral fluids. So maintenance fluids are needed. We can calculate according to the 4-to-1 rule, but need to be careful, especially in children with severe acute malnutrition, and may reduce this 4-to-1 formula to 70% or so. So we need to be clear in our training and management what are enteral maintenance fluids and what is fluid replacement. In terms of losses, there is a discussion about the use of standard hyperosmolar WHO ORS or Resomal, and this may be also addressed during the workshop. Now, the nutrition of the sick child. We need to start, ideally, once vital organ functions are stabilized, but we may not be able to start full feeds right away. And this is important in the severe acute malnourished child and the non-malnourished child. We can start gradually, and the later speakers will talk more about basic metabolic rates, which milks to use or feeds to use, and different further aspects. So it's important to recognize that the nutritional care of the critically ill child during this critical care phase is different to the nutritional rehabilitation described by WHO for the severe acute malnourished child. This can only really be initiated once the child is stabilized. Okay, so this is this presentation. The idea was to give a quick overview on essential pediatric emergency and critical care. So quick introduction. Jay worked for many years in global health. He is very experienced and spent a lot of time in Kenya and other countries. He is associated with the University of Oxford and works mainly in Kenya, in Kilifi, and with the Kenyan Medical Research Institute. Jay has a lot of experience in treatment of critically ill children, infectious diseases, and malnutrition. So over to you, Jay.
Great, thanks. I'm going to have to be quite quick because I've got to step out for another meeting and then come back in an hour's time. But I have shared this presentation by email as a PDF, and happy to come back to any questions when I come back. So I'm giving this presentation on behalf of the Chain Network. And the Chain Network was formed to answer the question really of why children are continuing to die despite the application of current guidelines in hospitals in low and middle income countries. We know that anthropometry and clinical features can predict death, but they don't always indicate the mechanisms that we should be targeting. We're also sort of coming from both the critical care and nutrition background and are very aware of this UNICEF theoretical framework, which I think Hans mentioned. There's a lot of underlying factors which lead to children becoming severely ill and affecting their outcome, social and socio-economic factors leading to poor nutritional status and disease severity. So one thing about this diagram is that I was always struck that nobody had put any numbers in it. So very theoretical. We aim to try and put some numbers on this. So we set up a network of 9 sites across Africa and South Asia, aiming to cover a wide range of settings, urban and rural, and different levels of HIV or other sort of diseases like diarrhea or malaria. And we did 3 types of study, and I'm going to focus really only on the first one in this presentation. So we did a clinical nutritional cohort study to see, which children died and look at information about why they died. We also did some very detailed social science work in households in Kenya and Bangladesh, and we have ongoing a very large systems biology study to understand mechanisms. And we're basically aiming to look at actionable interventions. We recruited children, acutely ill children aged 2 to 23 months. We weren't looking at neonates, and actually mortality in as a population it drops very low after 2 years on a community basis. So we went up to 23 months, and we recruited 3 strata, so non-wasted children, moderately wasted children, and severe wasting or kwashiorkor, so severely malnourished children. We enrolled them in admission to hospital, and we did observations every day. At discharge, we did more data collection, visited home, and then we followed them up for 108 days. And if they died in the community, we did verbal lots. Just to say that the collection was detailed, with not only sort of daily detailed data on clinical features, drugs being given, maternal mental health here, but also GPS mapping households, so looking at distances to hospitals, looking at sort of livelihoods, water sources, economics. I'll jump straight in with a very quick presentation of results. So we deliberately stratified these children into these 3 groups. So we had about 1,100 non-wasted children, 1,200 severely malnourished children, and about 763 moderately wasted children. When we looked at what kind of illnesses they were treated with, we were really struck that they were extremely similar. So there's very little difference in the profile, be a little bit more diarrhea in the malnourished children, but generally a very similar illness profile. We looked at when mortality occurred, and what we saw is actually in all 3 of those groups, almost half of the mortality was occurring during that 6-month period of follow-up after discharge, with no heterogeneity between strata. And we were interested in that because we'd previously seen post-discharge mortality in severely malnourished children, but not so much looked at in the other nutritional groups. There's a lot of mortality occurring post-discharge. When we looked at deaths were occurring, we actually were surprised to see that the majority were occurring at home without readmission to hospital, and that was more common in malnourished groups. People weren't coming to hospital when the child got sick. So coming back to that UNICEF framework, actually developed a mathematical model, structural equation model, where we looked at those underlying factors, and we looked at nutritional status, signs of severity of illness, and mortality. And we did different models. This is the model for mortality within 30 days of admission. We also did one for within 180 days of discharge. And what we see is that when we measure the nutrition status, we're actually also measuring a lot of underlying factors. And I don't think that's very surprising. The other thing, obviously, low nutritional status and high signs of severity of illness directly cause mortality. But I think the biggest surprise was how much these underlying factors were also directly causing mortality without being indicated by a nutritional status or signs of severity. And it really means that unless you assess these things, you're getting an incomplete sort of risk assessment. And this model has a very high predictive ability, and it's much higher with those underlying factors. When we use all this to sort of make load into a sort of score, what we see, and I should say that this is on a log scale, so this is more 30-day mortality up to very high rates, is that although we tend to think of these children as separate groups, we have non-wasted, and there's one protocol for them, and then there's severely malnourished, they have another protocol for them, and then there's moderately wasted children in the middle. There's a lot of overlap in their risk of mortality. Obviously, the severely malnourished are the highest, but there's many moderately malnourished children. These are individual children in these points with a mortality risk which is very overlapping with severe malnutrition. So the question then is sort of why and what we can do about it. So I'm going to give you some small sort of tasters of what we've thought in there. The first was to go back to our sort of very big data set on all the sort of individual clinical features and lab features and things, and just to say, if we forget about any prior knowledge or definitions of syndrome, pneumonia, diarrhea, and things like that, and we just say, let's take the data and put it into a machine learning model and say, what groups does the data identify? And in fact, we asked it to identify 6 groups. So we have 6 clusters, and this is around 3,000 children. And we've asked the machine learning analysis to find the most important predictors of 30-day mortality and then identify 6 different clusters, types of children. And so if I just quickly run through this, so cluster 1 on the left here has red means good, red means sort of higher, So they have very good nutritional status, and they have very little of anything else. Group who have very little wrong with them. And this group 1 is about 20% of all admissions. And group 2 have sort of the same, but they have worse sort of average nutritional status. So they have worse nutritional status. And this is actually the biggest group. It's this group here. It's about number 2 is about 1/3 of all admissions. And then almost another, we find that we have group 3. And here, these nutritional markers are blue, which means that they're low. So they have low nutritional markers, they have low age, but they don't have very much else. And that's group number 3. So that's the green group here. So that's almost another 1/3. And then we have 3 much smaller groups. So group 4 don't have very bad markers of wasting, but they do have a high level of nutritional edema. And they also have a very low albumin. That's 4 in the blue. This is a typical kwashiorkor case, but without sort of very severe medical complications. And then group 5, an interesting group, who Hans has already mentioned, who have low nutritional status, but not extremely low. They have some other signs, potentially some signs of circulatory impairment, like delayed capillary refill time, difficulty drinking, raised white cell count. But the big thing that they have is they have raised markers of renal function. So these are the children with renal impairment, acute kidney injury. So this is the blue group on the small slice of blue on the left side here, on the top left here. But that's a relatively small group with AKI and malnutrition. And then the final group 6, we didn't look for these groups. These are what machine learning pulled out. It's children with malnutrition, with edema. So this is your kwashiorkor children. But now they have lots of markers of severe illness. So this is basically kwashiorkor with severe illness, low albumin is group 6. And that's a very tiny group here, this pink group right at the top. Sorry, there's a lot of information in a short time, but essentially, without asking it to look for nutritional status, without asking it to any particular clinical features, these are the groups that the machine learning pulled out. And to us, they make a lot of sense. You've got the first group 1 who basically in hospital. You've got group 2 who are sort of average hospital admissions, but non-severe illness. And then you've got these 4 groups with some level of malnutrition, which clearly divide by the presence of kwashiorkor with low albumin and edema, plus or minus of severe illness. And when we look at the survival time over the next 30 days of those children, it's very striking. The 6 cluster survival curves look like this. So if you're in group 1, it's actually a little less than 1% mortality over 30 days. And these children, we think, actually could review the following morning and the discharge. And when we look at our sort of next day data, there were a few who had, were a little bit worse and they could be kept in hospital. But we think about 20% of children could actually be either not admitted or discharged very soon after admission. Then we've got the group which I described as your sort of average hospital admissions, but they don't have very signs of very severe illness with 3% day mortality. Then we're on to a couple of groups which are I would say the sort of not very complicated malnutrition. We've got the 9% in the essentially more wasted children and the 13% in the more edematous children. But those are the 2 groups with severe malnutrition, but essentially not with very, very severe signs of illness. And then we have these 2 groups right at the bottom. And if I just go back a slide, just to remind you of those, these are the last 2 groups. So the first group with severe wasting and acute kidney injury, group 5, and the second group 6 is severe with edema, with low albumin, and without acute kidney injury. And so we see those 2 groups have a very dramatic mortality risk. And these, I think, these are really suggested, these will be very difficult to manage at a sort of district hospital level. I'm going to speed up a touch and then finish a little bit. Just to give you a taste, we're doing, I mentioned that we were doing a lot of systems biology to try and answer the question, why do these children die following WHO guidelines? And we've got some immunology work in the pipeline, hopefully coming out soon. We've got work around LPS endotoxin exposure, which is coming out soon. We've got work around aflatoxin, which is coming out soon. And we've also got a very large integrated systems biology model looking at sort of metabolomics, everything omics, which is also, we hope, will come out soon. But one thing that we have published already, which was based on some pilot work that we had previously done, was that we saw in malnourished children that what seemed to be the biggest drivers, sort of mechanistic drivers of mortality, were systemic inflammation, and that's in the middle here, this panel of cytokine assays. And if it's on the right-hand side, this was higher in death. And if it's on the lower left-hand side, in the middle here, it's lower. It's lower in deaths or higher in survivors. And so we see a classic pattern of inflammatory cytokines, and at the bottom we see some sort of anti-inflammatory cytokines. So that's sort of something. Using our sort of metabolic panel, what was the impact of all of different levels of metabolites? And the really big thing that stood out was things which were in the TCA cycle. So this is essentially mitochondrial dysfunction. And when we mapped these pathways onto the sort of, the classical TCA cycle, they really block in the sort of electron trans chain and the ATP generation. This is something that's well recognized in sepsis, but not previously, I think, recognized in malnutrition. And what we think is that those children with both the severe illness, sepsis type presentation, they have one reason for sort of impaired mitochondrial function, and the severe malnutrition they have another reason for mitochondrial impairment, because they both seem to be impairing these similar pathways. And so we think that these children are getting a double hit. So we're now sort of looking at exploring treatments to improve mitochondrial function. And we're also exploring how these change during recovery after discharge. So that's just a sort of a taster from the systems biology work. I'm going to finish there. And I could stay on for a couple of minutes to take a few questions. And I did have some reserved slides, but I don't think we've got time for those. But I have emailed everyone on the call a PDF copy, and I have to drop off right soon, but I will be back on for the last hour, and would be happy to discuss further then, but happy to take any questions for 5 minutes or so now. Over.
Yeah. Thank you very much, Jay. That was a very, very important talk. And any questions at this stage? Cynthia, can you please look at the chat?
Yes, if somebody have questions, please, you can put in the chat. In this moment, have one person need, if it's possible. Dr. J, thank you very much for your participation. Excellent explanation. One person asked here, I think for you, if you can speak a little about rehabilitation, or if you have some data about the rehabilitation at this point in the nutrition.
So we are working on the nutritional data. There's a couple of very interesting things that come out, which is a lot of the sort of normal measures of dietary intake and food security really don't mean anything. They have very little contribution to models of mortality, and they also have very little contribution to models of growth. But the big thing that comes out of all of those models is actually socio-economic. So when we looked at something like access to hospital, we looked at geographical access, so travel time, travel cost, GPS coordinates and distances and all that. None of those things were important. But the big thing that was important, and I think Hans alluded to this earlier, was ability to pay. So it was the financial factor. And we feel that the same is true of the nutritional factors. We get actually very little from the sort of measurement of diet and diversity, dietary intake, food security. But what we get a lot of is access to those things, which has been limited by financial status. On the mechanistic side, we haven't completed, but we're working on all the sort of markers. We're doing lipidomics and amino acid profiles and other things, but we're still working on that. I saw somebody asking about what the sort of key takeaway messages are. A couple of key takeaways for me are, these are, the children with the sort of 9, 13 or 57 or 97% mortality are extremely complex children, and we would need a very large step up in the capacity to care for them to make substantial inroads into mortality reduction. On the other hand, I think we could gain a lot by giving less care to the lower risk groups, and that would free up resources and staff to care for those children. I think that what we also see is that different units have a different emphasis. Some units had a very big emphasis on nutritional care, and some units have a very big emphasis on critical care, and other units have a very big emphasis on infectious diseases. And they have a different kind of outcome according to that focus. But we need to have some better integration of the malnutrition care guidelines with the infectious disease guidelines and the emergency care guidelines, the ABC, the WHO ETAT, because currently they don't at all match each other. And I think we need to go through those, and they need to be really within WHO, need to be brought under one roof, I think, to try and get a sort of single coherent set of guidelines. I think that's something that could be done. I think that rather than make small changes to nutritional formulas and things, I don't think that's going to have any impact at all. I think there does need to be some research with sort of some fundamentally different approaches, and that's like is going on now with sort of microbiome directed foods, and also this sort of issue of dealing with this very intense inflammation which persists after discharge, and also the mitochondrial dysfunction and other things which I think will come up. And there are treatments that can be used for those, which is important.
Yes,
So
Dr. J.
the question: can you identify groups 5 and 6 from admission? Yes, I think certainly group 6 should be very clear. They're severely wasted, they're edematous as well, and they have signs of critical illness. So they're pretty easy to identify. However, they're going to be the most difficult to change the outcome, and it's a small population. Group 5, I don't think we can identify the acute kidney injury children without doing some lab tests. So doing a urea creatinine. I think it may, it's difficult to get a history of anuria and things, you're not passing urine and things, but I don't think they can be identified without some lab support. Okay, I better. Is there any other key burning questions? Otherwise, I need to jump off for another meeting before I come back on in almost an hour's time.
Yeah,
Okay, no
thanks
problem,
a lot.
There's a quick question.
Thanks a lot.
Quick question about timing. There's a quick question about timing after deaths after discharge, which I think is really interesting. So I think that there's a small peak of deaths immediately after discharge, which is really important. So we had some children who died on the same day that they were discharged, and some children who died the next day after they were discharged. And I think this is nobody's fault. I think that these are children who we see on the ward, mostly malnourished children who are watered in the morning. And you think, well, this, the child's not got any specific issues. They're malnourished things, but you can't identify anything specific. And then they die suddenly in the afternoon or overnight. And they're very, very brittle children, and they die suddenly. So those sudden deaths seem to be continuing to occur after discharge. I don't think, I think unless we develop better ways of understanding, and hopefully some of the mechanistic stuff might help provide some biomarker of more sort of physiological stability, they're going to be very difficult to not discharge. And keeping in hospital is probably not a good thing, because there's a high risk of nosocomial infection. And then the other post-discharge more deaths were spread out over the 6 months pretty much. Okay, so I'm going to drop off there, but I will rejoin on the hour in about 45 minutes time. So, and they're also happy to catch up in other ways if people are interested to discuss further.
Yeah. So much. Now I invite Dr. Alison Daniel, is a consultant in the Department of Nutrition and Food Safety at World Health Organization. She was involved in WHO guideline for prevention and management of the wasting and nutrition oedema, and is now working research priorities and other activities like in the guideline. Please, Dr. Alison, welcome with us. You can speak, please.
Thank you so much. And hi, everyone. Really happy to be here for this meeting today to really just give you a very brief snapshot of the guideline and some of the evidence gaps. And I also just want to acknowledge that many GDG members are here, or Guideline Development Group members. Jay, who just spoke, Robert, who will be speaking later. I saw Indy and Ida online. And also just want to acknowledge Kirli, who's also speaking after me, who is part of the WHO team for the guideline and really made this work happen. Just on the screen, there is a QR code to the guideline, which I'm sure many of you have already accessed. But just to kind of compare to some past WHO guidelines, this guideline has built on others in the past, including the 2013 guideline, the scope of which is shown in the dotted line in the middle there. It focused on severe wasting and nutritional edema, whereas the WHO guideline has a broader scope, including infants less than 6 months of age at risk of poor growth and development, which I'll talk about soon, also focusing on moderate wasting. And then at the bottom there, prevention of wasting and nutritional edema. The 2023 WHO guideline is built on several different guiding principles, which I'm not going to go into detail about today, but just wanted to acknowledge these and point out that it really is from the lens of a child health perspective, children's health, growth, and development at the forefront. Just some brief background about how this process was undertaken. So we engaged a guideline development group, or GDG, of 27 external experts who had a range of technical skills, different perspectives, geographic representation, and gender balance. And their roles were really, firstly, to determine the scope by prioritizing guideline questions. So there are many potential additional questions that should be addressed in WHO guidelines that could not be covered. And we really had to look at the most pressing needs. The GDG then reviewed evidence syntheses or systematic reviews and formulated evidence-informed recommendations based on the evidence available. And importantly, declaring and managing interests of all contributors was a key part of the process. Again, just some more background. We follow the GRADE approach for guidelines, and this is a collaborative, transparent decision-making process with well-established methods and standards. And I do want to point out that evidence is essential to inform decisions, but it's not sufficient, so judgment is required by the guideline development group. And importantly, for recommendations, we assign a certainty of the evidence and strength of the recommendations in the guidelines, which has implications for implementation of recommendations in different contexts. And we follow a GRADE evidence to decision framework, looking not only at effectiveness evidence, but also things like cost effectiveness, equity, acceptability, and feasibility. This is a structured and transparent way to look at judgments across these domains and use those for recommendations. As I said at the start, this is really just a snapshot of the guideline, and I'm just going to focus on a couple of areas that I think might be relevant to this audience, but we'll note that there's a lot more to this guideline than what I'll be talking about today. But the first subsection is on management of infants less than 6 months of age at risk of poor growth and development. And I want to note that this is a new population for the guideline, and we outlined several different criteria for identifying risk. And I will note that this is not a definition by any means. Now, these criteria were informed by prognostic evidence, which was actually quite limited in infants less than 6 months of age, and expert experience from the guideline development group, and really aim to fill a gap there beyond the neonatal period. But on the top there, this includes infants with poor growth based on sequential measures. On the bottom there, infants with poor anthropometry based on a single measure if sequential measures are not available. And these include MUAC less than 110 millimeters for infants between 6 weeks and 6 months of age. Weight for age Z score is below -2. Weight for length Z score is below -2, and nutritional edema. Then on the left-hand side, infants at risk due to poor birth outcomes. And on the right-hand side, infants with known risk factors for poor growth and development. So the guideline development group also came up with good practice statements, which are actionable statements that don't require a review of effectiveness evidence to know that there would be benefit in providing these interventions. And here's one example of one for these young infants at risk of poor growth and development, and around the decisions about supplementary milk in addition to breastfeeding, and that those decisions must be based on a comprehensive assessment of the medical and nutritional and feeding needs of the infant, as well as the physical and mental health of the mother and caregiver. And this applies to infants who are enrolled in outpatient care or admitted into inpatient care. We also updated this recommendation from the 2013 guideline, and you can see part C there where it says updated, and that was the specific part of the recommendation where we found some new evidence to change this recommendation slightly. And that states that infants who are less than 6 months of age with severe wasting and or edema who are admitted for inpatient care should not be given full strength F100 if they're clinically unstable and or have diarrhea or dehydration and or nutritional edema. We did also float the idea of expanding this recommendation to the broader group of infants at risk of poor growth and development, but the GDG felt that we did not have the evidence to do so. So that's the only update to that past 2013 recommendation. The second subsection of the guideline is on management of infants and children with wasting and or nutritional edema. And this includes moderate wasting as well as severe wasting. And this is another recommendation that we updated from the 2013 guideline. We had an in-person GDG meeting to go through hundreds of prognostic factors and look at those from a clinical perspective and try and make updates to these recommendations, including this one here on admission criteria for inpatient care. So you'll see that the actual recommendations are expanded upon in terms of what the danger signs are, acute medical problems, and so on. Those are detailed in the remarks of this recommendation, so I really advise that everyone read those remarks because we spent considerable time on those and actually outlining what the criteria are. Another update to this recommendation is in Part B there for infants and children with severe wasting and or nutritional edema who do not meet any of the criteria from Part A, but who have any of the following characteristics below are likely to benefit from an in-depth assessment to inform the decision possible referral to inpatient care. And that includes if children have medical problems that do not need immediate inpatient care, but need further examination and investigation, medical problems needing mid or long-term follow-up care, and with a significant association with nutritional status, and so on. We also updated the recommendation on when a child with severe wasting and or edema admitted to inpatient care can be safely transferred to outpatient care. And this is actually a strong recommendation. Children have to meet all of these criteria, including not having any danger signs for at least 24 to 48 hours prior to the transfer time, medical problems that prompted admission having resolved to the extent there's no longer a requirement for inpatient care, and a few other criteria there in that Part A. And then there's some other detail there that is quite important about not basing this decision on anthropometric criteria, such as specific weight for height or MUAC. Instead, the above criteria should be used. Also, importantly, caregivers must be linked to appropriate outpatient care with nutrition services, and additional social and family factors should be identified and addressed before transfer to outpatient care. We also have a new good practice statement here on accurate classification of hydration status in children with wasting and or edema who have diarrhea or other fluid losses, and emphasizing the importance of this and monitoring appropriate treatment and frequently reassessing hydration status. I will note that we did commission a DTA review or a diagnostic review to look at how dehydration can be identified in children with moderate or severe wasting or edema. And the review provided very low certainty evidence that did not directly answer this question. So the GDG was unable to make a specific recommendation there. We also have some recommendations around use of Resomol for children with severe wasting and or edema who are dehydrated but not in shock. And if Resomol is not available, then low osmolarity ORS can be used. And we have another recommendation specifically for moderate wasting, and that these children, when they're not in shock, should be given osmolarity ORS in accordance with existing WHO recommendations for all children apart from those with severe wasting and or nutritional edema. And then another recommendation here, which is a new recommendation around the use of hydrolyzed formulas. And this recommendation states that for infants and children with severe wasting and or nutritional edema who are not tolerating F75 or F100, there is insufficient evidence to recommend switching to hydrolyzed formulas. But this is another scenario where I do advise that you look at the the remarks to determine if there are certain cases when this might be appropriate, which we've given some input on. So there were really many evidence gaps identified throughout the guideline development process, and we do actually want to update the guideline as new evidence emerges. And some priority areas for updates would be new guideline questions. So I talked at the start about the need to prioritize guideline questions, but that there are many more that could be on the table in the future. We would also aim to update recommendations, especially those that have low or very low certainty evidence. And I did mention, for example, for that DTA review, that the GDG couldn't make a recommendation. So there are also guideline questions that we looked at that didn't have relevant evidence and could also be addressed as new evidence emerges. And we'll also say that there are too many examples of evidence gaps for me to talk about, but I alluded to that there were gaps around the need for an effectiveness of supplemental milks for infants less than 6 months of age, as well as breast milk fortifiers, and those being predominantly in inpatient settings. Another evidence gap is around whether admission for inpatient treatment based on specific criteria that I talked about actually results in better outcomes for children with severe wasting and or edema. There are also questions about how to assess and classify hydration status in children with wasting and or edema, and also comparing moderate versus severe wasting, as well as inpatient versus outpatients. But more importantly than me telling you all of these evidence gaps would be actually getting your input on what these are. We have just launched a first survey for a CHINRI exercise to come up with a WHO research priority agenda for the populations of interest for this guideline. And we have a list of research questions from the guideline development process. But for this first survey, we would like to get input on what additional research questions we should put on the table for scoring in the second phase of this CHINRI process. So please, if you're able to, take a look at the survey online and complete it if you're able to. So I think I'll stop there. Hopefully I didn't go too much over time, but happy to answer questions either verbally or in the chat if we've run out of time. Thanks so much.
Kirili currently works for UNICEF. As Alison mentioned, she was part of the guideline development group of the WHO guidelines. Kirili also worked for many years with MSF Belgium and as a nutritional referent, and has extensive experience in different parts of Africa and around the world. So Kirili, please, over to you.
Thank you, Han. I'm just going to share. Oh, no, that's sorry. However long we've all been here, we can't quite get it right with the technology, can we? Okay, is that all right? Can we see? Can everybody see the screen?
Yes, sir.
We can see well. Thank you.
So I'm a bit of your kind of break from all the smart people this afternoon, because I'm just going to come and repeat a lot of things that everybody else has said and basically go on a bit of a rant. So as Anne said, it's nice that I'm following on from Alison, who did such amazing work on the WHO guideline. So like all of us doctors and medical people, we have our stories and we have the patients we can't forget, don't we? And I'm sure there's hundreds. Well, how many are we online? Over 100. There's so many of you online who have these kids in your head. And that's why I'm here. And that's what I'm still doing this topic. And that's why I'm frustrated on a daily basis, but why we keep going. And I know loads of you who have had this patient on the left here, you're looking at him and going, and indeed, he didn't make it. And this was in a well-resourced MSF hospital in Sierra Leone. And unfortunately, the questions I had then about how to manage him, I still have today. And this was 2012, I think. So, I mean, even starting with the fact with kwashiorkor, we don't know what causes it. We don't know why the child who was in the bed next to him with marasmus did better. And even the fact that we don't know what the cause of kwashiorkor is, even though there's lots of work going on and some great work coming out of Chain that Jay's working on as well, we still don't know. Then a little boy on the right, I had examined this boy top to tail myself. And I followed the MSF protocols religiously. And I didn't give him vitamin A because he had edema and there was a theoretical risk of liver damage. But after being on a night shift, 36 hours later, I came back and I found he had this cloudy cornea and he's lost his vision. And I kept digging into, but why? I should have given that vitamin A, but I didn't, because it said there was this risk of liver damage. And, you know, all those questions that still haunt me, let's say. And so I think for many of us as well, we think about, well, if I did have this child in the London PICCU where I trained, would he have done better? What would I have done differently? And as Jay said, these patients are so complex, and we can't expect in these low resource settings to be able to do the same thing we do in some high resource settings, unfortunately, today. But there are things that we could do, and we should be able to be closing that gap a little bit. But I still think about how mortality in these settings can be up to 40%. I just asked my old boss this morning, what was the mortality in the hospital I trained at? It was a tertiary hospital in London, and their PICCU mortality is 3.9%. So we and that's still quite higher, but we still see these huge differences. And then I kind of want to take you on the hamster wheel that goes in my head. And when you think about it on a global scale, these are probably only, what do we think, about 10 or 20% of the children overall with severe acute malnutrition who have to be hospitalized. Yes, okay, so it's a kind of a small amount. And then I think to myself, and this little boy, it wasn't overnight that he came like this. This was a long process probably of him getting this sick. So actually, should we be focusing our efforts on the community, on prevention, on that outpatient care, picking up those kids? Yes, we should be. And actually, if you look in a lot of the recent efforts, there has been a lot of focus on that. So almost now we are neglecting a bit to do that work on the inpatient care. And it is where we'll have impact on mortality. It is where we can actually do something about these children who are dying in front of us. The children who are hidden from us are dying in the community, maybe not, but the kids in front of us, we could do something for them. So what more can we do? And this is the question which I go round and round and haven't got the answer to. But it is also the reality that I followed all those protocols that I had, those MSF protocols, and I'm guilty because I also then wrote the MSF protocols later in MSF. I followed them religiously because I was a British doctor trained in the UK and I'd never seen kids like this. But it was only after a few years of doing this that I kept thinking, is this the right thing? Some of it seemed quite against my pediatric training. Is this right? Is this? And when I would dig and I would ask people, eventually I came to realize, and it's the same realization that we have today, that a lot of the WHO guidance we have for management of these really difficult, complicated cases comes from evidence which hasn't gone through the WHO process that we have today. So a lot of it, in truth, is based on smaller studies. It is based on physiological studies. It's based on a lot of clinical experience, which doesn't mean it's wrong. And we all have I have my experience and I think it goes like this. But we do question things now that we've all inherited. There's a lot of things we've all inherited and we've seen, and it's a bit dogma, and we carry those on. And I think there needs to be the time that we question that. Even some things like, for example, when you see your acceptable mortality rate in a lot of these national protocols, it will talk about 10%. Where does that come from? The sphere standards of 10% was for humanitarian emergencies, but we're applying that to hospitals and in sometimes unstable contexts. Is that right? Should we be questioning that? So those issues that kept me busy on all those night shifts are the same issues that I'm struggling with today in my role as UNICEF, which is helping governments update their acute malnutrition guidelines. I've seen the names of some of lovely colleagues also online who we were in Togo earlier this year. We did a workshop for experts who are going to be supporting governments on updating their national acute malnutrition guidelines. And again, we were also all struggling. Is this the way to do it? Should we be doing more of this? For those big topics. And what are those big topics then? Well, our big fear of fluid overload. As Hans said, we know we have to be careful with fluids for sure, but our management of dehydration, our management of shock, blood transfusions, I keep seeing national protocols again and again recommending the same things. But is this right? Is this a time that we should be questioning this a bit? Are we actually letting those children slip from dehydration into shock because we're not managing them aggressively enough? There is some work going on with the Global Cholera Task Force about maybe adapting some of our approaches to fluid management for cholera for malnourished children based on increasing evidence of actually not as much difference as we thought in cardiac function between malnourished and non-malnourished, but the kind of evidence that wasn't there in the earlier studies which have informed a lot of the guidance that we use today. And what about when these kids don't improve? When I've still done telemedicine cases for MSF, it's the same cases we see over and over again with the same questions. What second-line antibiotics should we be using? And then I'm sure you've done it just as much as I have. There's that moment where you've tried everything else and you've treated their malaria, and then you add in an antifungal, another antiparasitic treatment. Is that right? Should we be doing that? Should we not? Most of the time, we don't have the tests, the investigations to tell us what's right. And then diarrhea. I'm going to give you, I bet so many of you seen the same thing, where they came in really sick, so they had their IVs then they probably didn't improve. So you added in a second line IV. Then they've gone to the oral relay, and either they start or they keep having this diarrhea. And maybe you're fluid managing them and it's not being too dehydrated, but it's not resolving. Oh, okay, well then maybe let's add in some tinidazole. Oh, and then we've added in some albendazole. And in a line of a few days, you see kids who've been on about 5 medications for that diarrhea. Is that the right way of doing this? I keep thinking as well of these malnourished children with their guts, which are completely not working at all, which the smart people later on will talk to you a lot more. Is that the right thing? Or kwashiorkor skin lesions? If we don't know what causes kwashiorkor, what about those skin lesions? So I know in MSF, we talk to a lot of dermatologists, but again, to be able to treat a wound, you usually need to know what causes it. But in the end, we ended up treating it much like we did burns in kind of an empirical approach, but we don't have the evidence behind it. Our nutritional management. The truth is we take a very public health approach to complex nutritional care. We use the same therapeutic milks for all kids. We're not measuring their electrolytes. We're not measuring anything else, and we hope for the best. And then that feed intolerance. You're putting the F75 in and you're watching it come straight out of their bum. And what do? Well, we dilute the milk a bit, or we slow it down, or we give it slower. And yes, actually, sometimes that works. But again, it's a very public health approach to really sick kids. And what about enteral feeding the critically ill child? Are we just going to leave them NPO, or are we going to do something about it? Which relates to my next question of, we've all seen that kid as well who's not malnourished, but they're in a coma because they've had severe malaria and they've been nil paros. And you look at their chart and realize, oh, it's been 3 days. And yes, you've been managing their glucose, but how long are you going to leave them like that until they've got SAM? So already we have to think about nutrition for those critically ill children. What about the nutritional needs of these critically ill children? It's not easy to often be able to make those assessments in these low resource settings. And then our enteral feeding. When are we going to start it? How are we going to start it? We don't have pumps in a lot of places. And what are we going to give? Your Sundalis Junior is very rarely available. You're going to give all these kids F100? It's probably not an appropriate substance to give. And then the question we've had so many times, and I've seen so many protocols, to gastric aspirate or not to gastric aspirate when you're doing this enteral feeding. These are the big questions. So I'm just going to finish now. We know that there are guidance gaps. We know that there are research gaps. I hope we've got some of our donor friends online who might pricking their ears up and realizing that there is some really important research which needs to be funded. My wish list is that we can update the normative guidance about how to measure these children and their complications, taking into account the available research, but also hopefully then really inspiring people to do more research so that we can really answer these questions and be able to treat these children better. And I have this photo up to give me hope, and again to remind us as well of, as I said, these MSF telemedicine cases I always get the child not responding to nutritional treatment, and I write back, it's TB or HIV, you haven't diagnosed it yet. No, we've tested that. It's TB or HIV, you haven't diagnosed it yet. And then they'll come back and say, oh yeah, actually it was, yes. This is a little girl here, an absolute adorable girl. And after 2 weeks of TB treatment, which we started empirically because everything else wasn't improving, and then look at her after 2 weeks of treatment. She's a new person. So I keep that to give me hope to keep going. I hope it gives you all hope to keep going. Let's increase that research. Let's get better guidance. Let's do a better job for these children. Thank you for having me, and I'll stop.
Robert is an associate professor at the Department of Nutritional Sciences at the University of Toronto. He's a pediatric gastroenterologist and nutritionist for sick children, sick kids in Toronto, Canada. Robert published in multiple scientific manuscripts in various journals and was also part of the WHO guideline development group for the nutritional guidelines. So very welcome, Robert, and over to you.
Hello, everyone. Hope you can all see the screen and see it in the right presentation format.
Yeah, we can see. Thank you.
So I'm very grateful for this invitation, and because I think this meeting brings together two communities that have not interacted sufficiently, I think, for the last decades. So my talk is going to build, I think, on some of the frustrations and add on some of the frustrations that Curly and Alison and Jay also talked about. I think this is a great opportunity because and Curly can, I think, attest to that, our global malnutrition community has been dominated over many decades by the nutrition community mostly. And of course, a lot of success, a lot of improvements were made, and it provided a foundation for how we manage acutely ill, malnourished children today. But as Carilli also pointed out, many of these children that we manage currently, the WHO guidelines really don't fit very well anymore. So I'm going to talk a little bit about that. I'm also grateful that we do have people in our community now that are able to bridge the critical care community with the malnutrition community. And in particular, people like Chisti Dobayer from the ICDDRB, who is an intensivist and is also part of our chain and network as well. Because I think people like Chisti are able to, or would be able to really advance this field significantly. So I'll share first some of my learning objectives. So I was asked to specifically talk a little bit about the nutritional aspects and the intestinal aspects. So that's what I'll do. I'll dive a little bit deeper into some of the pathophysiological understandings that we have currently and where some of the gaps lie, and with some perspectives on future research that I think is sorely needed. So this is a typical child that we see in many low-resource settings that come to hospital. They have underlying severe malnutrition, and then they develop an acute intercurrent illness. I think it's important to realize that many children with severe wasting who come with an acute illness actually have multiple diagnoses. And Carilli mentioned TB, HIV. Often there is a chronic illness and then an acute illness on top of that, and sometimes, even more than one or two diagnoses. We know that these children are very vulnerable, right? This is data that I think they also talked about, showing that if you follow these kids up from the moment to admission for 6 months, these children with severe malnutrition have about a 5 to 7-fold higher chance of dying than children. So they're really, really vulnerable. And one of the main challenges is that as clinicians, we're very poor at identifying who is going to do well and who's not going to do well. So this is data from Rieger Fosco, who looked at all kinds of different early warning signs and see how well they performed in children with no wasting and children with severe wasting or kwashiorkor. And of course, many of these are familiar to you, like the Pew score, for example. They're very simple clinical scores, but they really help to identify which children really need, more intense monitoring, might be on their way to the ICU, etc. So it's clear that these warning scores do not perform well in children with severe malnutrition, and that's what, as clinicians, we've known, or we subconsciously or perhaps consciously knew for a long time, that they don't develop the same symptoms. They don't necessarily develop the same degree of respiratory distress if they have a pneumonia. They don't develop the same degree of fever that we would expect in a child with a bacteremia or sepsis. And that really poses a challenge for us in managing these children. I'm going to talk, the first part of my talk, I'll talk about the nutritional aspects, because, we were talking about disconnects between the critical care and the global malnutrition community. And I think this is an important area where there is a big disconnect. So when we treat these children, we give them F75, and according to the WHO guidelines, we give them about 90 kilocalories per kg per day. The F75 is mostly sugar. The protein is kept relatively low, and that was, the thought was that if you give too much protein, you might induce more refeeding syndrome, and they won't be able to metabolically handle that. But think about that number of 90 kilocalories per kg per day. There is growing evidence, both from the sort of high resource nutrition and critical care communities, that if you are acutely ill, you should not overfeed and you should not underfeed. And that balance is very, very tight. So if you are, especially over long periods of time, severely underfeed, you remain very catabolic and you won't be able to really build up that resilience. However, if you overfeed, and this is on the x-axis, you see the resting energy expenditure, so really the minimal energy that a child would burn if it was awake and just lying but not being very physically active. That you should not, and the growing evidence suggests that you should not feed beyond that resting energy expenditure, and perhaps probably slightly below that. And some of the strongest data comes from this trial that was published in New England now about 8 years ago, and it was preceded by an adult trial whereby they delayed, in this case, parenteral nutrition in critically ill children. This was in high income settings, mostly European and Canadian cohort. And they delayed more aggressive feeding with parenteral nutrition for about 7 days. So look at the sort of the difference in the calories provided. So these children were on average about 10 kilograms. So they would start in the delayed parenteral nutrition with about, 10, 20 kilocalories per kg per day, and then slowly build it up to about 60 or so, or 70 after 7-8 days. Whereas in the standard of care, they built it up much quicker. And what these studies in adult and children found was that if you give delayed parenteral nutrition, so delay more aggressive nutritional management, you do better. You have shorter hospital duration of stay, shorter ICU stay, and a lower risk of new onset infections. They did a subsequent analysis whereby they identified the children who were malnourished in that cohort, and they did a specific analysis on those, and they found the exact same thing. So the same results basically, and it really affected the paradigm and the thinking in intensive cares, perhaps more so in Europe than in North America, where I think in North America they were already a little bit less aggressive with feeding, and it really highlighted that you should be very careful and avoid overfeeding in children who are critically ill. And remember, the population that we served, the severely malnourished, acutely ill population, they have a mortality rate that's higher, as Carilli also noticed, than in many high-resource ICUs around the world. So what we did as part of a chain sub-study, we actually measured their energy expenditure in these children. So the SAM is severely malnourished, NAM is non-malnourished children. And what we found that the children with SAM had a somewhat higher resting energy expenditure, and that's probably true because they don't have any fat mass, they don't have muscle mass. And so basically the RE is determined by, heart, brain, lungs, etc. And they have a higher metabolic rate than muscle and adipose tissue. But still, the amount of energy that we give, if we give F75, and if they won't take it orally, we often give it via NG tube, is significantly higher than the RE. So what we're currently doing is currently a phase 1, phase 2 trial whereby we are looking at reduced calorie F75, and so about a 1/3 reduction in calories, or a 50% reduction in calories, and that's with the RCDDRB, with the group of Chisti, Yobayer, and Farzani Afrozi, another pediatrician in Bangladesh, and we're doing it also with a group in Malawi, whereby we want to see, one, is it safe to actually reduce calories? We know these children are at risk of hypoglycemia. And then, is it effective? And it would require a phase 3 trial after this initial trial. So that's a piece around the nutritional aspects. I'll now say a little bit about the role of the gut and also how it relates to nutritional care. So we know that severely malnourished children have a very damaged gut. They have villus atrophy, so shorter villi, so their absorptive capacity is reduced, and they have a leaky gut, and they also have gut inflammation. So leaky gut meaning that bacteria and bacterial products can more easily translocate into the bloodstream and cause either inflammation or full-blown sepsis. So because we know they have a degree of malabsorption, and a trial that's now already quite a few years ago looked at reducing the glucose amount and removing the lactose from F75 to see if it would make a difference in the outcome of these children. Because you have to realize that these children, if they develop diarrhea, it's osmotic diarrhea. So it's triggered by the food that's being given, and that's what's driving the diarrhea, right? So it's not a secretory diarrhea for the most part. But unfortunately, it didn't make a difference. So of course, here calories weren't affected, but just reducing sugar does not do the trick. And then another aspect is the digestive organs are also affected, in the sense that we know that there's hepatobiliary dysfunction, so there's not as much bile being produced. And of course, bile, with their bile acids, are very important for lipid digestion and therefore also absorption. And also the exocrine pancreas, which you see on the right, is severely affected. And basically these children behave as children with cystic fibrosis. They have not even moderate, but severe signs of exocrine pancreas dysfunction, which very likely affects, both their protein absorption and their lipid absorption. With that in mind, and also realizing that these children have a higher amount of bacteria also in their upper gut, they have what we call often a small bowel bacterial overgrowth. We know that pancreatic enzymes and bile acids have antibacterial properties. We thought, okay, let's give these children pancreatic enzymes and bile acids and see if it can both, reduce their mortality and also their diarrheal symptoms, perhaps even affect their growth as well. But unfortunately, again, another negative trial, we didn't see any impact. And if anything, we saw potentially a negative impact of the bile acids. So I think this group of studies, and there's other studies, antibiotic studies and probiotic studies, they've all been negative trials. So that tells you that this group of children is very, very, very difficult to manage and very difficult to improve their care on. I mentioned that leaky gut, which you see again here in this slide. There are other groups that have also tried to see, okay, what if we can restore gut health? Does that affect their outcome? And this is a study from Paul Kelly's group with a trial that's called the TAME trial, whereby they tried different interventions in ill, malnourished children. So they gave either colostrum and acetylglucosamine. So we know that glycosylation, which has also been shown in, for example, inflammatory bowel disease to be defective, but also potentially in severely malnourished children, and they're important for a leaky gut. So this potentially could restore that. The deglutide is a gut proliferation medication, and budesonide is an anti-inflammatory. And they looked at various inflammatory and other gut health outcome markers. And they did see a trend for some of these medications. It didn't combine the different interventions here, which I think would have been also helpful. But potentially there is some value there, and I think this needs to be looked at further. And then finally, we've talked about it's been mentioned, microbiome-directed therapy. And Jeff Gordon's group in St. Louis, he has been at the lead of this, much together with the group in ICDDRB. And this is their latest study where they gave a microbiome-directed food called MDCF2 compared to ready-to-use supplementary foods, a group of malnourished kids, and they looked at their wasting outcomes. And they did see a small effect in terms of wasting outcomes. So potentially there is something there, but you have to realize these foods were different in many different components, including for example, their protein amounts, etc. So it's difficult to really compare these two foods, and it might be microbiome independent, the effect that was seen. But can it actually improve mortality? That's another question. Jay alluded to our chain data where we looked at multi-omics data, and we also looked at microbiome data. And there wasn't really a clear microbiome signal that was associated with mortality. So maybe there is something we can address here, but it could also be that this is ultimately going to be a dead end. I think we need more data on that. Another area of research that's been hugely neglected is the role of micronutrients. So when F75 and the different formulations that are being used to treat severely malnourished children, when they were developed with micronutrient deficiencies in mind. So as you can see here, many of the micronutrients are given beyond the recommended daily intake, which is sort of the dotted line there. But however, some were not. So for example, sodium was kept very, very low, with the idea that the actual total sodium body pool is higher than is reflected by the serum sodium, which I think is one of the dogmas that needs to be challenged, because I don't think it's actually true. And there are other, especially some of the B vitamins that are not being given in that high amounts. And especially if you have a deficiency, it will not quickly correct the deficiency. And it might be important for some of the organ functions that reduce these children's resilience. However, you also have to be careful about restoring some of these micronutrients quickly. So this is a study that's published a couple of years ago in Nature Communications, whereby they looked at the effect of different micronutrients supplementation on the microbiome. And what they saw was that if you give micronutrients, you can potentially worsen their growth of pathogens and allow certain pathogens to grow at a higher rate, because many of the pathogens also utilize the micronutrients that were being given. And only by adding additional zinc, you could bring it back to a sort of normal level of pathogen growth. So that means that if you were thinking about adding extra micronutrients to these nutritional products, you might also potentially do harm. Jay mentioned this work whereby we looked at omics data, especially metabolomics data, to see, okay, what signals really come up when we look at children who die versus who are discharged alive. And again, it was a combination sepsis-like inflammatory signals and signals that relate to mitochondrial dysfunction. And as you know, as critical care people, in critical illness, mitochondrial dysfunction has been long recognized to play a role, right? You have reduced tissue perfusion, you have acidosis, you have oxidative stress, and they all relate to mitochondrial dysfunction. And then you have, in our malnourished population, the malnutrition in itself that's affecting mitochondrial dysfunction. And we also have generated data that it can potentially also play a role in the leaky gut that these children have, and perhaps contribute there to some of their mortality risk. So indeed, are there ways to restore mitochondrial health quickly? And I'm again thinking about some of these micronutrients that are perhaps not giving adequately, and perhaps there's opportunity there. But again, many questions remain. I would like to end with this slide. I think, I hope, also with the presentations that were given before, that the group of patients that we care for are very heterogeneous. They often have multiple diagnoses, and they're not unlike the children that you care for in higher resource settings, in ICU settings. So I think it's naive to think that with a single bullet intervention, one particular drug, one particular micronutrient, or one small change in feeds, you're really going to significantly affect their outcome. You really have to think, what are the pathways, the biological pathways that are related to their poor outcome, and can we address all the different factors that are perhaps impaired along that pathway together and not in isolation? And I think for that, we need your community. So with that, I would like to end, and here are some take-home points I hope you got from this presentation. So one, many of the trials that we've done over the last decades have been negative trials. So we've not made a huge impact in reducing their mortality over the last 2 decades. The children that we currently end up with are very, very sick, multiple diagnoses, and we need to think about intervention packages rather than silver bullet interventions. It's important to realize the continuum of care. Jay mentioned the post-discharge mortality. So these children remain vulnerable for a longer period of time. There's data that we didn't show, that's also produced by someone in Jay's group, that immune deficiency also remains present for months, perhaps even longer than that. So they remain vulnerable from an immune function perspective. We need to think about more precision approaches rather than a one-size-fits-all. But most importantly, we need to foster collaborations between the critical care community and the malnutrition community if we really want to make an impact for this very challenging population. Thank you.
I would like to invite Dr. Morbidity. He's a leading research pediatrics and an expert in infectious disease such as pneumonia and tuberculosis. He is currently embedded with the Department of Nutritional Service Division at the ICDDRB, a world-renowned research institution in global health. Please, Dr. Mohamed, if you want to put your slides to initiate your talk. Welcome. Thank you so much.
Thank you. I'm just going to share my slides.
No problem?
No, should not be a problem. Okay,
I can see you.
So are the slides visible?
Yes, perfect.
Okay, thank you very much. So I will have a very brief overview, as time is only 10 minutes, on nutrition of the critically ill child, experience from Southeast Asia and Bangladesh, update on current clinical trials. So we prepared this presentation with the help of Dr. Arun Bansal from India and me, and I will going to share my presentation now. Thank you. So I have nothing to disclose. So as you know that recently we have come across to know that children who require hospitalization, especially in low resource and middle income countries, we found that among 13% of them are present with pediatric critical care illness. So, and among these 13%, most of whom are present with either pneumonia or septic or cascade of septic shock and malaria. And overall case fatality rate among them is 6.3%, but most of these deaths occur in Southeast Asia and Sub-Saharan Africa. And almost 2/3 deaths occur within first 48 hours of their presentation. And it has been found that severe acute malnutrition is one of the predictors of mortality. And it has been found the significant proportion of death occurs due to severe acute malnutrition, especially in Southeast Asian region, especially India, Pakistan, Bangladesh, and sub-Saharan Africa, especially in this where very irrespective of HIV status. And
sorry for interrupting, Dr. Chisti. I apologize. I just wanted to ask if you could put the presenter mode so it's easier for the people to see presentation. Yes, is that one.
Is the presentation is not visible?
It's visible, but if you click there on the icon on the bottom, on the right.
Right?
Yes, this
is
one.
Okay?
Perfect. Amazing. Thank you so much, and sorry for the interruption.
Oh, sorry. I'm also sorry for this. Okay. So, as you know that among 2 million under 5 deaths, it is also known that 45% of these mortality occurs from severe acute malnutrition, and children who require critical care illness, among 30% of them also falls under severe acute malnutrition. That does mean that if we can manage severe acute malnutrition appropriately, we can reduce these deaths from the children who require critical illness. So, as you know that many of these deaths can be avoidable with the access of best evidence-based critical care intervention, preventing acute stabilization in terms of fluid resuscitation and providing medical oxygen and vital organ support. Unfortunately, healthcare system in low-income countries and lower and middle-income countries are often poorly resourced, especially in these basic needs, and these are poorly managed. And in fact, recognizing this gap in critical care, recently World Health Organization come across to take the lead and advocates to strengthen and integrate this care into these children, and they advocates to enrich the critical care system, especially for the children, needs to be more strengthened. And from that perspective, it is also mentioned that nutritional management should be an integral component for better management of these children. However, nutritional management, especially in malnourished children, either it is moderately malnourished or severely malnourished, yet not going to have the evidence-based. And I want to initially emphasize on the nutritional management of children with moderate acute malnutrition. Till today, we didn't find any evidence-based guideline for the management of the moderate malnutrition. And thus, with the lead of WHO, recently we had just started, it is still going on. It has been started since 2023, and including Bangladesh, India, Pakistan, Mali, and Tanzania, among children 6 to 23 months, where children with the moderate acute malnutrition were enrolled, and they were selected from children with acute diarrhea or a non-severe pneumonia or malaria, or if there is fever 4 to 6 days requiring hospitalization, and or this patient might be managed from the outdoor. And this a group of patients are going to have management of the microbiota directed complementary feeding versus ready to use supplementary food versus locally available food. And almost 3/4 sample size have been achieved. And the primary outcome of this study, which is the recovery to no acute malnutrition, that is, children shift from the moderate acute malnutrition to no malnutrition. And hopefully by the end of this year, this study will give us some insights. And if we see the nutritional management of severe acute malnutrition, you can find that we need to manage it in 3 components, especially in acute stage by the clinical stabilization, and also treatment of underlying infections, and also nutritional rehabilitation. And our main focus for this presentation is to nutritional management during the clinical stabilization. And what we have found from in the different studies done till date, we have a systematic review where we have found that 9 relevant studies where we wanted to see whether there is a nutritional intervention to reduce the mortality. And there is 9 studies we identified, 4 from Africa, 3 from Asia, and 2 from Latin America, and which is done by one of our colleagues in ICDDRV. And that study, this systematic review included the study, those do not have any control intervention, that is placebo, or any control group which do not have any intervention. We don't have this control group. There is actually historical control group, and none of the studies provide sufficient information whether they have scrupulously adherent to the WHO guideline in each step of the dietary management. And all the pool analyses were based on random effects model. And what it is done, that study showed very low level of heterogeneity. And the analysis showed the serious risk of bias due to lack of adequate controller confounders. And due to lack of adequately designed studies in systematic review, this systematic review actually provided very low quality evidence. But still, with this evidence, what we have found that adherence to WHO guideline is associated with the reduction of around 41% mortality among children with or without HIV. And if we exclude the children with HIV, there were only half children remains, which also shows that there is 45% reduction of mortality if there is adherence to WHO guideline. So given with this adherence of WHO guideline in many hospitals in settings of Southeast Asia and Sub-Saharan Africa, the mortality still ranges from 8 to 16%. And that does mean that this management guideline needs to be substantially improved. And this death mainly occurs due to different reasons. And as already shown by Professor James Barclay as well as Dr. Basma, how the death occurs not only in acute stage but also in the post-discharge stage, it is multifactorial. And you can see that among all deaths, most of the deaths occur due to a lot of comorbidity. And among the main comorbidity in Bangladesh and India mainly occurs due to comorbidity of pneumonia, sepsis or septic shock, dyspnea, and also improper handling of the dietary management. But most of the culprit here is a septic shock. It has been shown that in children with severe malnutrition, among the all deaths, around 70% deaths occur due to septic shock. So it is the out of scope of discussing this today. So I will today only focus on dietary management. So in dietary management, already Dr. Basma showed that in the acute stage, WHO aimed to provide around 90 kilocalories per kilo per day, which seems that there might have chance of overfeeding. Why this speculation is there is some logic behind that. And recent observations and high-quality randomized trial from the ICU in the high-income countries demonstrated that overfeeding to critically ill patient is harmful. And what we have found in a study in Bangladesh, that children who were severely malnourished and still required admission in the ICU, among them, 17% developed ileus, which is defined as the development of abdominal distension. And if we perform the X-ray of the abdomen, we have found that there the gas distended bowel loop with the multiple fluid level, which is very dangerous. And among all deaths from severe acute malnutrition, 30% of those deaths occur from ileus. And that ileus supposed to occur in the early, very aggressive feeding. So this is one of the things that we, in our mind, come that present feeding practice recommended by the WHO might be overfeeding and harmful. And other logic is that a large clinical trial delaying parenteral nutrition in children admitted to an ICU, what has been shown already by Dr. Basma, that reduced overall calorie intake as well as improved clinical outcome, including the risk of new onset of infection and the reduced duration of ICU admission and trend towards higher proportion of being discharged alive. And Robert already have shown this figure. I will not discuss in detail, but you can see that late parenteral nutrition compared to early parenteral nutrition is really helpful. And study revealing resting energy expenditure, that also shared by Dr. Robert in collaboration with actually Malawi. And this is the study which has been done at the sub-study of the Childhood Acute Nutrition Network, which has been presented by Professor James Barclay. And in that study, what we have found that the energy expenditure was higher in severely malnourished children than the non-malnourished, the non-wasted children. However, the energy expenditure that occurred, it is much lesser what we are providing now according to WHO guideline. However, we don't know what is the optimal level of calorie that we need to offer for these severely malnourished children, because we are finding that there is energy expenditure which is much more lower, and simultaneously we find that there is acute feeding with that amount of calorie and volume. There are significant amount of development of ileus which has a high mortality. And from that perspective, Professor Benton showed that we had designed a study applying a lower caloric feeds during the initial stabilization phase, where there will be survival of critically ill children with malnutrition in low resource setting. However, reducing caloric intake in these children may increase the risk of hypoglycemia. So we are conducting this study as a pilot study to understand the safety, evaluating the episodes of hypoglycemia. And we are doing this in 3 arms, following the Bayesian model. And you can see that if you have 75 versus F50 and if you have 35, we are performing this in collaboration with Sick Hospital, headed by Dr. Bensma, and also it is in collaboration with our chain network, headed by Professor James Berkeley. And this figure also shown by Dr. Bensma, where we shown that we are enrolling patients after screening initial stage. It is the safety trial. This is why we are enrolling severely malnourished children with only maximum of 1 danger sign. And we are following the Bayesian model for that. And we have the continuous glucose monitoring and the initial stabilization phase, the clinical stabilization phase, which used to take 2 to 3 days. And we have a transition phase where we will use for both the sites and the ready-to-use therapeutic feed. And patient improve to the catch-up growth, we will discharge them from our rehabilitation unit. And this is the thing that we are still doing. And from this presentation, what we can conclude that the pediatric acute critical care illness is a huge public health problem, especially in low resource setting, and have the high mortality. And most of these deaths occur due to malnutrition. And many of these deaths are avoidable with access to basic and evidence-based care intervention. And nutritional management is one of the key components, but it is not the single most bullet, as already mentioned by Professor Berkeley and also Dr. Bensma. We need complete package of management, but for the nutritional management point of view, we can say that we need to improve and we need to have the basic and evidence-based management for children who are critically ill and also moderately or severely malnourished. They need to have the very evidence-based guideline. Hopefully, the study which are going on there those will give us some insight for the future. But we need to have the package of management to reduce the mortality of the inpatient, especially in the acute stage. And also, I think that post-discharge management is a critical issue to reduce overall deaths from malnutrition. So there's the reference which I have used for this presentation. So thank you all for your questions here.
We now will invite the team from Ouagadougou, from the Centre Hospitalier Université Delgado-Ouedraogo. Just a few weeks ago, I had the chance to visit the CHU in Ouagadougou during a training we conducted with the Joseph Kiserbo University in Ouagadougou. So, Prof. Caroline Yonabo is a very experienced pediatrician who is based in Ouagadougou. She is originally from Tanzania, and she has also particular interest in pediatric HIV. Dr. Angel Sakal-Mogo is an associate professor of pediatrics at the Joseph Kiserbo Uni in Burkina Faso, and she's been leading the nutrition and vaccination unit at the Delgado-Ouedraogo University Hospital since 2013. She is actively involved in supporting national health programs, and she serves as a regional and national trainer for the management of acute malnutrition, pediatric HIV, and early childhood psychocognitive stimulation. So we hand over to Dr. Angel, and very welcome. You are, vous êtes bienvenue de parler aussi en français, et je suis sûr que nos collègues peuvent suivre votre présentation. Merci beaucoup et s'il vous plaît, à vous.
Merci bien. Je vais laisser la présentation sans la vidéo pour le moment parce que la connexion est assez instable actuellement chez nous. Et avant tout propos, permettez-moi de remercier les organisateurs pour l'honneur qu'ils font à notre équipe de présenter notre expérience au Burkina Faso. Et nous félicitons donc l'organisation et c'est un plaisir pour nous de présenter notre expérience de la nutrition de l'enfant malnutri, l'enfant gravement malade et traité dans un contexte de ressources limitées. Et l'équipe est composée de Dr Kalmogo, de Dr Diallo, de Dr Yonaba et du professeur Koïta. Il faut dire que la malnutrition est un problème de santé publique dans le monde et depuis ce matin, ça a été dit dans beaucoup de présentations. Et au Burkina Faso, nous sommes un pays, une superficie de 272 000 km² environ et une population de 20 millions. Et la capitale Ouagadougou compte 2 500 000. Et il faut dire qu'avec les défis sécuritaires, on a la population qui est de plus en plus grandissante liée au déplacement des personnes en interne. Nous avons des infrastructures publiques et avec 4 centres hospitaliers universitaires et 5 districts sanitaires avec 2 centres médicaux et 15 centres médicaux environ avec 16 CSPS qui sont des centres de niveau 1. Et les infrastructures privées comportent plus de 300 formations privées. Sur le plan épidémiologique, nous pouvons dire que la tendance globale de la prévalence de la malnutrition dans notre pays est en baisse. Et si l'on prend de 2009 à nos jours, 2021, pour la malnutrition aiguë, nous avons 11,3 en 2009 et nous sommes passés à 9,7 en 2021. Et pour la malnutrition chronique, nous étions à 35%. Et nous sommes passés actuellement à 21,6%. Pour l'insuffisance pondérale, nous sommes passés de 26% à 17,5%. Et par rapport à la supplémentation en vitamine A qui se mène lors des campagnes, nous sommes à 77,1% en 2021. Il faut dire que le centre hospitalier universitaire Yalgado est notre service actuel et nous sommes l'un des 4 CHU du Burkina Faso, donc qui avons pour objectif de recevoir au niveau de la pédiatrie les enfants. Et lorsqu'on prend ces enfants, nous avons une capacité d'accueil d'environ 173 lits avec 5 unités et 2 structures annexes. En ressources humaines, nous avons un professeur titulaire avec des pédiatres et également des paramédicaux avec des attachés de santé, des infirmiers, des sages-femmes. Et nous avons un nutritionniste avec le personnel mobile, avec les stagiaires internés, les paramédicaux et puis le nutritionniste. La mission de notre centre est d'assurer les soins. Nous assurons le diagnostic, le traitement des malades. Et également, nous participons à l'enseignement, que ce soit l'enseignement universitaire ou post-universitaire en formation continue. Et nous participons également à des activités de recherche en santé, ainsi que les actions de santé publique, telles que les recherches, l'éducation pour la santé et la prévention. Les indicateurs de la malnutrition aiguë sévère dans la prise en charge en interne dans notre centre du 1er janvier 2021 au 31 décembre 2023 s'est fait au niveau des urgences pédiatriques et du service de nutrition et vaccination. Sur 8 767 patients hospitalisés, nous avons inclus 373 enfants principalement. Et les indicateurs de performance ont donné un taux de guérison de 82% environ, un taux de décès à 11%, un taux d'abandon de 5%, et le gain de poids moyen dans le centre était de 11,94%. Et lorsqu'on prend les décédés, à leur admission et ce qu'ils ont présenté au moment du décès, on avait la fièvre dans 56% des cas et les difficultés respiratoires dans 40% des cas, les vomissements dans 36% des cas, la diarrhée dans 29% des cas et sur le plan paraclinique, on avait une hypoglycémie chez 52% de ces enfants qui sont décédés de malnutrition aiguë sévère. Par rapport aux aspects thérapeutiques, la prise en charge, lorsqu'on va sur notre expérience, lorsqu'on a notre parcours, nous avons, c'est vrai, d'abord l'évaluation de l'état nutritionnel de l'enfant. Nous évaluons également la sévérité de l'affection de l'enfant et nous évaluons les besoins nutritionnels. Et pour ces besoins nutritionnels, après ces besoins nutritionnels évalués, nous décidons de la voie de traitement à faire et s'il va s'agir d'une alimentation orale, entérale ou parentérale et assurer également le suivi jusqu'à la sortie. Par rapport à la malnutrition aiguë sévère, avec complications médicales que nous prenons en charge dans notre service, et nous utilisons les recommandations du protocole national de prise en charge de la PCIMA, qui est actuellement en révision pour se mettre à niveau par rapport aux nouvelles recommandations de l'OMS en 2023, où le principe du traitement est de corriger le désordre électrolytique et les carences, de renutrir le malade de façon progressive, de traiter les infections, de traiter et de prévenir l'hypoglycémie et l'hypothermie et de traiter également toutes les complications qui sont là. Et donc, comme on l'a dit, cela ne pose pas de problème. Nous avons le protocole national où nous nous inspirons de ce qui est là-dedans. Et pour la prise en charge de l'enfant gravement malnutri, nous avons l'enfant qui est incapable de se nourrir et où nous n'avons pas la possibilité également de faire la voie parentérale. Nous avons donc recours à la nutrition entérale artisanale. Et il s'agit donc de préparation fait maison ou bien l'utilisation de lait thérapeutique tels que le F75 et le F100 qui ne sont pas forcément adaptés pour les enfants non malnutris, mais qui est la ressource dont nous disposons au niveau du CHU. Nous avons également les aliments thérapeutiques prêts à l'emploi que nous utilisons et nous le faisons passer par la sonde nasogastrique. Comme point à améliorer, nous avons le problème des infrastructures où au niveau de notre réanimation, nous n'avons pas un monitoring adapté pour la réanimation de ces enfants. Et nous n'avons pas également de nutrition entérale préfabriquée qui est indisponible. Et nous n'avons pas la possibilité également de faire une gastrotomie. Et le suivi par le nutritionniste de l'alimentation des enfants de façon spécifique également et adapté au cas n'est pas fait. Lorsqu'on voit que ces enfants souvent qui sont dans le coma ou qui ont plus de 5 ans et qui ne sont pas malnutris, ou bien les enfants qui présentent une infirmité motrice avec d'autres problèmes de santé spécifiques, l'oncologie essentiellement, nous n'avons pas un protocole qui nous permette de façon claire de faire donc cette alimentation. Nous sommes obligés donc de recourir à cette nutrition que nous disons donc nutrition artisanale. Et comme acquis, nous avons la nutrition entérale qui est possible par la sonde nasogastrique dans le centre. Et cela va permettre le maintien de l'intégrité fonctionnelle et de la motilité gastrique. Et nous avons également les équipes qui sont disponibles et qui sont engagées. Et nous avons la gratuité des soins depuis 2016 chez les enfants de moins de 5 ans, qui permet donc de faire face à la prise en charge médicale surtout parce qu'avant cette date, on avait des difficultés pour les enfants de faire face au traitement médical et également le traitement nutritionnel. Et ce traitement nutritionnel également accompagné par les ONG. Et ces appuis des ONG se fait à travers la direction de la nutrition, notamment l'OMS, l'UNICEF, l'IRC, le PAM. Et également, nous sommes en train de faire un état des lieux de la nutrition entérale au cours donc, de l'hospitalisation de ces enfants qui sont dans des situations particulières et qui ne sont pas sévèrement malnutris. C'est pour dire en définitive que autant nous avons des orientations sur la prise en charge de la malnutrition aiguë sévère dans notre contexte, nous avons des difficultés pour la prise en charge des enfants qui sont gravement malades, notamment les enfants qui sont dans le coma, les grands brûlés et les enfants qui ont des pathologies spécifiques telles que les cancers, l'infirmité motrice cérébrale, ou bien les enfants qui ont plus de 5 ans. Donc, il est nécessaire pour nous de trouver un protocole national validé pour cette catégorie de personnes. Je vous remercie pour votre attention.
We will now switch over to another francophone country, Madagascar, and Prof. Diavolana Andriana Rimanana speaks very good English and German, so I think she can do her presentation in English. And I have the pleasure to work together with Dia in a uni partnership, and we were conducting together with her team training program over 2 years or 2.5 years in one region of Madagascar. So we'll present the situation in Madagascar. So please, over to you. I just want to mention as well, besides being a pediatrician at Isanga, she is also a hospital director and a very busy person. So over to you, Dia.
Well, thank you for this presentation. So we will present the situation, a particular situation of Madagascar. So we'll talk about HIV and malnutrition in Madagascar because we have a particular situation now. Talking about Madagascar, Madagascar is the 4th biggest island in the world. It's like France with the Netherlands and Belgium and Luxembourg together, and 27 million inhabitants. We have a very high rate of severe acute malnutrition, 8 to 10%, and this severe acute malnutrition is cause of 44% of under 5 deaths. Madagascar, as an island off the coast of mainland Africa, we have a very big impact of climate change, and perhaps you have already heard about the drought in the south and southwestern coast of Madagascar. But there is a contrast in the other side of the island, in the eastern coast. We have multiple cyclones. Each year we have almost 16, and this has an impact on crops, food stocks, and also this is the reason of a high rate of malaria in this coast. So, for example, a referral hospital of the region of Buenima-Janga, the prevalence of severe acute malnutrition with complications is 5%, with a case fatality rate of 17.4%. Madagascar in numbers. Madagascar, more than 3 in 4 children are poor, almost 8.6 million children. And we are talking about malnutrition. 47%, almost half of all children under 5 are stunted. So it is the 5th highest chronic malnutrition rate in the world. And only there are 28% of children aged 5 to 17 are already economically active. So this is the side about economic and cause of malnutrition. We're talking now about the HIV, because besides all these challenges about climate change, about socio-economic problems, we have also in the last years other big problem, and it is the situation of HIV. If you are comparing with our neighbor next door, there is a Comoros, and with the UN-AIDS data 2023, there is a change in new HIV infections since 2010 there is 151%. I think there is only 2 countries in the world who are like the situation now in Madagascar. And the change in AIDS-related deaths since 2010 is 279%. And the incidence prevalence ratio is now 12.7%. The incidence mortality ratio is 2.5. So this is a big challenge. The problem is Madagascar was considered the HIV epidemic long thought to be concentrated on key populations like sex workers, men who have sex with men, and intravenous drug users. And as circumcision is, I can say, systematic in Madagascar, it was seen like there will be no problem in HIV. But Madagascar has also a high burden of sexual infectious disease. So the circumcision have lost their advantages. And during a long time, unfortunately, the uptake of the epidemic, it was during the COVID epidemic. So it was not seen. But now there are evidence that there are surge in HIV across population and regions, indicating the transition of the epidemic into the general population. And we can see it in these trends of HIV prevalence and incidence in Madagascar from 2010 to 2024. In 2019 is what uptake slightly, and during the COVID epidemic, it was rising. After 2022, it explodes. So it was like a perfect storm. And if we can see the trends of HIV prevalence per district in Madagascar from 2021 to the first semester of 2024, we can see this uptake of new infection. And we can see this in the hospitals, because now we have from severe acute malnourished children, 318, from 52 of them are affected in the referral hospital I talked before. And we are talking about severe acute malnutrition, 39 from them are infected. And this number of new HIV cases admitted in the pediatric ward of referral hospital Andruva, we can see the rise of the cases. And most of them are admitted in the intensive care for severe malnourished children. And that is why the situation is normally we should have do the diagnosis of these children from the mothers, but it's upside down. It's because the children are admitted, and the tuberculosis program that is mandatory to test HIV in tuberculosis, in malnutrition. That's why these children were diagnosed. And we can see it. Most of the children, almost 70% of them, when they arrive in the hospital, they're already stage 4 of HIV. So we missed opportunities already during the pregnancy to avoid the transmission of mother-child HIV. So the situation, as I told before, it was especially in the southern Madagascar that the program fighting malnutrition, that the detection of this very higher rate of HIV positivity in very severe acute malnourished children. But this uptake of early detection of HIV and ART in pregnant women should have prevented the occurrence of AIDS-related severe malnutrition in these children. So immediate collaborative action between national and international stakeholders to expand HIV interventions, bridge funding gaps, and deepen epidemiological understanding for a more robust national HIV response is needed. Because, as I say, there was a time 30 years ago with the uptake of HIV epidemic in Eastern Island Africa, and then it was in Central Western Africa. And now Madagascar is facing this challenge, multiple sides with the climate change, with socio-economic challenges, and now with HIV. Thank you for your attention.
It was a big pleasure. I will present the Latin America, the South America team. We have 2 speakers today. We have Andrea Rodrigues. She's in pediatrics in the Pereira Hospital, This is a university academic hospital, which is a member of the enteral and parenteral nutrition support unit in this hospital in Montevideo, Uruguay. And it's a part of the committee of the Society of Uruguay in Pediatrics. And we have Professor Arthur Delgado. He's associate professor in pediatrics department in São Paulo University. It's the most important university in the Latin America. That's a big university. He's head of the nutrition team too in the Hospital de Criança and Hospital de Clínicas in São Paulo University. And have a big expertise in pediatric critical care and clinical nutrition. And he have many contributions in these years to advancement in both fields through research, education, and clinical practice here in Latin America, South America, and in other countries. Welcome. And please, Andrea, you first. That's up to you, please.
Thank you very much. It's an honor to be here. Thank you for this nice presentation, Cynthia and Hans. We're going to share my presentation. I think it's possible to see.
Yes, perfect.
Thank you very much. I am Arthur Delgado and Andrea Rodrigues Vinoli. We are going to present on these 2 studies performed in Latin America to characterize the practice of nutritional support in Latin America with these studies. The first one is the Latin American Spanish Survey on Nutrition Pediatric Intensive Care. This study comprised a survey with a questionnaire sent to Latin American Society of Pediatric Intensive Care members. There was 37 surveys in 17 countries. 7 of the pediatric intensive care units were from university-affiliated hospitals with a median of 380 admissions per year. In this study, it's possible to see that the 68% of the pediatric intensive care had nutrition support team. Only 6.4% had indirect calorimetry. 72% of the intensive care had routine nutritional evaluation, but only 57% had nutrition support protocols. At day 3 of initiation of nutritional support, 58% of pediatric intensive care provided at 50% of calculated energy requirements, and 91% at day 5. To estimate energy requirements, the majority of pediatric intensive care used Holiday-Seeger and Schofield equations. 97% of the pediatric intensive care initiated enteral nutrition at 48 hours, 83% with gastric route. Preferential route is through continuous method. It's very important to emphasize that the conclusion of this first study is nutritional practice are heterogeneous in Latin America, but the majority use nutritional support strategies with international guidelines similar presented in the presentation before. To characterize better the pediatric intensive care nutritional practice in Latin America, this study performed between March of 2002 and February of 2005 evaluated 1,077 admissions, mean of 31 per month, and 53% of the patients at admission showed moderate to severe undernutrition. When analyzed infants, 41% of the population, almost 60% presented moderate to severe undernourished. The patients were undernourished. This is an important thing in this pediatric intensive care in Latin America. The undernourished patients are very frequent. Big part of the intensive care in university hospitals present patients with chronic disease. And it's very important to remind you that comorbidity and chronic disease increase very much the case of fatality in these patients. It's very important to investigate chronic disease in these patients because these patients can present a state of undernourishment and the mortality is higher. Dr. Andrea will carry on the presentation with other study performed in Latin America. Please, Dr. Andrea.
Thank you so much, Arthur. Hello, everyone. I thank the organization for the opportunity to participate of this event. I'm sorry, my English is not so good. Well, in this slide, I will comment the second article that has been written by SLACID Nutrition Committee, in which Dr. Delgado participates. The name of the study is Malnutrition and Nutritional Support in Latin America's PICCS. It consists on a single-day study where 41 from 13 Latin American countries participate. From Uruguay, we had 2 PICCS that contribute with data. The number of patients collected was 315. 67% of the PICCS were academic hospitals, and the majority were medical surgical units. Regarding the percentages of malnutrition, it was found that 50% of the cases on children under malnutrition, and in whole the percentage was 15%. As Dr. Arthur said, the vast majority of the malnourished children had at least one, and obesity was 6% in and 24 months. In this other slide, we like you to show about enteral nutrition support. That is the one that is preferred up to initiate the energy supply in our PICCS. There are two figures. The first one, it shows the prescription for energy and protein, the one that was indicated and the one that was received by the patient. That what was indicated, the patient could receive it. But in the second one, that shows the percentage of enteral nutrition delivered by energy and proteins, we have to say that the suggestion of the international guidelines for energy supply, when it was at the 6th or 7th day, there was a significant percentage that exceeds what is recommended by the guidelines. So that shows a risk of overfeeding. That was not equal to protein delivery supplies that was slower. Other facts that are interesting from this show is that 76% of the units had a nutritional support team, 69% routinely performed nutrition evaluation at admission, 41% had protocols, and what was said, interest calorimetry was just available in 5% of the units of Latin America. The next slide, Arthur. From Uruguay, we'd like to show you two articles that are just brief. This is my hospital, Hospital Pereira Rosell. We are a small country, but Hospital Pereira Rosell is the reference for the children in public system health. We are a medical chirurgical hospital and an academic one. In 2017, we have performed a study where the incidence of malnutrition was 26%, and where we apply a screening test for the risk of malnutrition during the stay in the ICU. We have 20% of the children that had a high risk of malnutrition. Anemia was frequent. Percent of the children under 1 year have anemia, and 67% in older kids. And in 2022, we have tested this again. The incidence of malnutrition was 14%. When we look for the energy supply at the week after admission, we can reach 84% of the calorie at the week of admission and 80% of the minimum protein suggested by the international guidelines. The last one, Arthur. And just to summarize some nutritional highlights, we like to say there's important to make a formal nutrition evaluation at admission. We have to check if it's needed to perform routinely the assessment for every child. First, a nutritional screening score to select the high-risk kids is very important to determine the energy. There are just few units that have indirect calorimetry, so the Schofield formula is what we use. We need to avoid underfeeding, but to overfeed. it was said in all the workshop. The minimum protein intake, it needs to be 1.5 grams kilo. We need to prioritize enteral support in the first 24-48 hours. Parenteral nutrition, not in the first week, is what's the recommendation of the guidelines. And to highlight the importance of to have protocols and nutritional support teams just for this kind of child in the ICU. Thank you so much.
Excellent, Andrea and Arthur. That's very interesting to listen you about the South America context and Latin America. That's very interesting. Dr. Hans, have some questions for you too, if you want to comment about this, about the basic metabolic rate, resting energy expenditure in the critical care phase. If you want to talk too about the short comment on the protein requirements in the critical care phase, please, Arthur or Andrea, you can comment.
I think that Andrea summarized very, very well in the lecture at this point. The minimum of 1.5 grams per kilo per day of a protein is required in the majority of the study. In the acute phase, the energy requirement is lower. It's very important to emphasize that in recovery phase, the energy requirement is very high, but in the acute phase, it's necessary to be careful with the delivery of energy to avoid overfeeding. Andrea, please comment.
I just would that these children have a high risk of refeeding syndrome. The mortality of the kids were not malnourished, and we have a highest of energy is higher. So we have to try to be careful in the acute phase, just like Arthur said, about the amount of energy. We are just more worried for the energy and not so much for the proteins. I think we have to take more that second recommendation and be careful with the energy.
Our next speaker will be Michael Pinar. Michael Pinar is a pediatric intensivist working in several pediatric intensive care units in Bloemfontein, South Africa, where he is an associate professor. Michael has also an interest in artificial intelligence, and important, Bloemfontein also receives patients from Lesotho, which is not far from Bloemfontein. So Michael, over to you, and thanks for joining us.
Thank you very much, Hans. Can you see my slides?
Yeah, perfect.
Okay, thank you very much for the invitation, and it's been a pleasure to listen to the very knowledgeable presentations today. I'm going to present a central South African experience of nutrition in critically ill children, and we're a small university and a small ICU, but we cover a very large geographic footprint, and I think there's some interesting contrasts in our practice. So we are in central South Africa, so our region is the Free State Province, but we provide tertiary level intensive care services to the Free State and the Northern Cape in South Africa, which is a very large, sparsely populated area. And then we also provide referral level services for our neighboring country, Lesotho. Within that space, ICU is a mixture, children in general ICUs, which is sort of the bulk of ICU services across that region, but widely spaced, particularly in the Northern Cape, only 2 ICU providing centers. And in terms of ICUs with intensivist cover, it's really just the Bloemfontein service, which is 10 general ICU beds and sort of 3 to 4 cardiothoracic ICU beds, and everything drains at a tertiary level through to Bloemfontein in the center. So while we have quite high level intensive care services in many regions in South Africa, the big problem is that because of our colonial and apartheid history, South Africa remains probably the most unequal country on the planet with a Gini coefficient of 0.65. And in South Africa, there's a great discrepancy between the average Black African South African who's earning on average 6,899 Rand or $360 a month, compared to the white South African who is at this stage still earning close to $1,300 per month. And in South Africa, what this boils down to is that about 28 million people, or 45% of our population, are still dependent on social security support grants for their livelihood. And what this means is that in a system where we have access to relatively high technology services in the ICU realm, there's a great many people who are using those services who are at risk of severe poverty and severe malnutrition. So in South Africa, there's a parallel healthcare service currently, although there's work towards unifying this into a universal healthcare system. But about 70% of patients is the public sector hospitals, which is broken down into different levels. So there's from primary healthcare through to smaller district hospitals, large regional hospitals that begin to have general ICU, and then the tertiary level hospitals with PICUs. So we have a real mixture within the public sector of resource availability from the tertiary centers, which are quite well resourced comparatively to the primary healthcare system and district hospitals, particularly in very rural areas. So if we go back to the map, an area like Springbok, right on the very western part of the Northern Cape, close to the border with Namibia, there's a district hospital there, for example, but there's not very equal distribution of resources in the system. And then there's the private healthcare sector, which is a mixture of general practices for the most part, followed by increasing levels of specialty and subspecialty, which is used by a very small portion, which is very well resourced relative to the number of patients that they actually attend to. So within the Free State and the Northern Cape, we have the greatest prevalence of severe acute malnutrition in South Africa. So data suggests that in the Free State, there's about 6.4 per thousand children with severe acute malnutrition. The Northern Cape, similarly, 6.2 per thousand. So high incidence within these provinces in South Africa. And in Lesotho, the problem is really even worse with very high rates of malnutrition. Within the system, the other thing to take note of is that while we're talking about in this presentation, critical care provision of nutritional care, access remains very limited in South Africa to ICU. So the last availability survey in 2007, there's approximately one ICU bed per 18,000 population in South Africa, and the minority of these beds are available to children. And I suspect that this ratio is probably worse now than it was in 2007 in the Free State. So we admit about 500 to 700 children to our PICU per year, but there really is a need to prioritize, given our constraints, children who have a relatively good prognosis with the provision of critical care. So in South Africa, for the most part, children with edematous malnutrition requiring life-supporting therapy are often not considered for PICU care, and those children tend to go into the pipeline for the WHO protocol, whereas we tend to provide slightly more bespoke nutritional care for the children that do end up in the ICU, which aligns more with the European Society's provision guidelines. Within our ICU, so we have a preponderance towards younger patients with a median age of about 4 months. But in that population, in the under 5 group, at least 16% of HIV unexposed children had a weight for age Z score of less than -3. And interestingly, both HIV-infected and HIV-exposed children without infection both had increased risks of being severely underweight for age at a statistically significant level. So 23% in the HIV-infected group were severely underweight, 24.5% in the HIV-exposed uninfected group were severely underweight for age. But within our service, we are tertiary level care, so we take mainly referral level patients, but we do have a large group of the generally critically ill patients with respiratory infections or sepsis. But we do have a fairly significant group of patients who are critically ill with malnutrition in the ICU. But then many patients in other areas like medically complex patients, abdominal surgery patients, etc., who are all at risk for malnutrition because of their underlying pathology. So we see a lot of very medically complex patients, and nutrition plays a role in most of those cases. So what does our nutrition team look like in the Free State? So we have a registered dietitian who conducts daily ward rounds with our patients. We don't have access to calorimetry. We use the Schofield formula, but we obviously have a large team involved in this, which includes our nurses, the intensivist team, our surgical teams, many of our other medical subspecialties like gastroenterology might be involved. We have pediatric hospitalists involved, and then other members of our rehabilitation team moving out of the acute phase and into the rehabilitation phase. such as our speech and language team to help us reestablish oral feeding, or where there's been some difficulty with swallowing, or in things like positioning for feeding with occupational therapists and physiotherapists assist. We make use of our palliative care team for most of our patients, and then obviously incorporated in this process, we have a number of trainees in our academic hospital. So we've got a wide spectrum of nutritional therapies available to us. We offer feeding via nasogastric tube, for some patients via nasovaginal tube, and then for quite a large number of patients via surgical gastrostomy. But we have the full spectrum of enteral feeding options that include breast milk. We have kitchen diets, specialized diets, but then also standard and preterm formulas, F75, F100, standard enteral feeds, soy-based feeds, partially extensionally hydrolyzed feeds. And we also offer parenteral nutrition through a closed system pre-constituted PN framework. And most of our parenteral nutrition that we use has gradually transitioned over the time from intralipid-based PN to SMOF-based TPN. But we have a number of practical constraints for the provision of parenteral nutrition, particularly in terms of safe long-term venous access. And we try to limit the use of parenteral nutrition to where it is entirely necessary. So in terms of our actual practical approach, within the ICU environment, we align as far as possible with the ethnic guidance, but we do have to take into account the constraints that we have within our own system. We practice as far as possible early initiation of enteral feeds. I think we would be sort of generally trying to initiate enteral feeds within the first 24 hours. And for most of our patients who are ventilated, this is via the gastric tube. And we provide bolus feeds unless there's some other compelling reason to provide continuous feeds. We pay very careful attention to the risk of both overfeeding and underfeeding, like other speakers have spoken about. And we, particularly in our unit where we mainly deal with younger infants, we are very careful to try to maintain or reestablish breastfeeding as far as possible in that group. What we do try to do after ICU discharge is where it's tolerable and possible, we try to maintain the presence of a gastric tube, especially for patients who have had very severe critical illness, because we know that they may have a protracted rehabilitation phase and they may not reach their nutritional targets purely by oral feeding alone. We continue the involvement of the registered dietitian after PICU discharge, and for many infants, there will be continued follow-up after ICU where that's feasible. But this is sometimes particularly difficult where patients live in remote areas. And then while we have access to PN, we practice delayed introduction of parenteral nutrition, given the literature on this. So we do have some challenges. So obviously from the map I showed you, our patients come from, in many instances, remote areas, and there can be protracted delays in referral. So, for example, patients from Lesotho, for example, referred for congenital intestinal abnormalities like jejunal atresia, may experience protracted periods where they're unable to cross the border into South Africa, and where in Lesotho it's not possible to offer them parenteral nutrition. And those patients can be really difficult clinical scenarios where we've got protracted periods of being NPO and where the patient now requires abdominal surgery and the patient continues to have difficulty with establishing feeding after that. Those patients can be very difficult to look after. We have had challenges in supply chain and cold chain with our feeding options. And in the region, we have this persisting high level of baseline malnutrition, and the interplay between this and the profile and the kind of critical illness that we see. There is still in South Africa a lack of access to critical care services, and this particularly leads to this population of critically ill children outside of the PICU. There is an influence of critical illness and PICU on feeding itself, which I will show you from our setting. And there is a concern in our setting about what happens with the continuation of nutritional care after discharge from the ICU and after discharge from the hospital, where we know these children continue to have increased nutritional demands long after they're in ICU. We have difficulties in making measurements of micronutrient status for many of the micronutrients. And then we have quite high rates where we use parenteral nutrition of complications, particularly CLABSI, associated with parenteral nutrition. But if you look at what ICU admission does to feeding practices, in our unit, we had looked at the role of breastfeeding in PICU in South Africa, and we do see that of patients who entered the ICU breastfed at discharge from ICU, only 63% of them had remained exclusively breastfed. And by the time we had reached hospital discharge, we had only managed to reestablish exclusive breastfeeding in 80% of those patients, which is a significant concern. And I think something we need to be sensitive to in an ICU where we have a very young population in the ICU and where we know that breastfeeding is a vitally important public health intervention. But in conclusion, in South Africa, there remains a high burden of malnutrition generally, as well as in the PICU environment. We're privileged enough to be relatively well resourced within the PICU itself, but there is a problem remaining in South Africa of adequate access to PICU and of services for critically ill children. And we continue to face several challenges despite being in a position of having relatively good resources. Thank you very much. Anyone wishes to contact me, there is my email.
Moment I will invite the next two speakers. They will talk about maternal nutrition and nutrition of the young infant. I invite Angela Gisti. She is a senior researcher in the National Institute of Health in Home. Her expertise include public health, research and interventions, a plea of epidemiology, quality and mixed method research, interview planning and evaluation, and health promotion and community participation, as well as training and communication too. And I invite to the Dr. Sing Song, the general pediatrics with 20 years of experience working with children and has further training in child development and infection disease. Over these years, she has worked with the humanitarian helping with the Medicine Sans Frontiers in many countries, and she's a strong breakfast advocacy and have qualified to do this since 2020. Thank you so much, Dr. Angela Gisti and Dr. Sian Sao. Please, can you speak your presentation?
Thank you, Cynthia. Can you hear me?
Yeah? Yes, very well.
Okay. I think Sian should speak before me, and I ask kindly Lorenzo if you can share the slides, please.
Thank you, Lorenzo. My name is Sao Xian. I'm a pediatrician in Malaysia, and I've been very honored to be invited to this workshop. My experience is mainly with Medicine Sans Frontiers and other NGOs in low-resource setting in Africa and Afghanistan. And my main base is mainly in Malaysia. So I'm a pediatrician and also a lactation consultant. Lorenzo, next slides, please. I will speak just very briefly. Me and Professor Angela have no conflict of interest disclosed as below here. Next slides, please. We will talk about breastfeeding and use of breast milk in low resource setting. As I'm a pediatrician, I will see things from my views as a pediatrician. Next slide, please. Next slide. I think this is just that all of us as humanitarians workers have seen. Low resource setting as this in a refugee camp in Sudan is a very crowded residential area with no basic structures. Therefore, our children, the families is very prone to many infections due to respiratory tract infection and poor nutrition, and in some environment might be hypothermia. And their caretakers, especially the mother, will have their own poor health and mental stress as well. As a pediatrician, I feel that if the mother can actually exclusively breastfeed young infants, many of these problems can be solved, as evidence cited by WHO. Next slide, please. So as a recommendation on infant nutrition, all of us knows that, is early initiation breastfeeding within 1 hour of birth and is exclusive breastfeeding with no other added fluid for the first 6 months and continue breastfeed beyond 2 years of age. Next slide. So in our opinions, across so many countries, I think that even in high or low resource setting, breastfeeding should be the default choice of infant nutrition, especially those younger than 6 months, at any situation, even in critical care ill infants, including in PICU. That, as the last speaker actually has mentioned, that we should actually encourage breastfeeding, but where do we have the correct environment for this mother to breastfeed their children, or even with true express breastfeed, and do we have a skill to actually encourage them to re-establish lactations. Next slide. So I think this slide actually has actually given us a guidelines. So if the mothers and the baby has come to the hospital together and they have actually breastfed before, let's actually encourage them to continue breastfeed, to especially direct latch. To if they have stopped breastfeeding and the mother is willing to relactate, let's help this mother to relactate. Okay, maybe we need to not undermine, even when we giving the artificial breast milk substitute, we can actually still help this mother to relactate on top of the artificial feeding that we're actually giving. Okay, if the mother and the babies are not together, for example, in a refugee camp, in the conflict zones, if there's actually a relative in the culture acceptance setting, we should actually look for, a witness, to help some of the, I've seen auntie, female relative actually help orphans to breastfeed, these orphans and actually help to recuperate health on these children. I think, to me, breast milk substitutes should be the third or even the fourth options for our children that in conflict zones and emergencies. Okay, of course, in MSF, we do have, a diluted F100 protocols for 1 to 6 months in TFC, but even though, I've used these protocols, then it's the latest protocols in my mind, looking at the minerals and calories, they're actually far inferior compared to breast milk. Next slide, please. So I think we need to see our children, from the views of a mother-child diet, as a lactation consultant, we see mother-child as a diet, like their point of views, as they actually breastfeed, they try to relactate or breastfeeding journey, what challenges they are actually facing. One mother might actually willing to breastfeed their child, to lactate the child, but they're facing a lot of knowledge gap and support from us as a healthcare providers and also their families as well. Okay, I will skip this slide. Okay, next slide. I just want to illustrate by 2 examples that I just come back from a TFC in Kano, Nigeria. This is a very classic examples. The twins born term at similar birth weight are actually growing quite at a similar weight gain together on exclusive breastfeeding. Unfortunately, the twin two have become ill at 4 months old with diarrhea. With the advice from the family and as well as the healthcare providers, they thought they need to give some such, breast, like some formula and help at, when the child was ill. After 1 month on these kind of regimes, the second twin in fact lost weight and become a severely acute malnourished and end up in our therapeutic center. This is only the 2 months of not breastfeeding. They can see the sizable difference between twin 1 and twin 2. So we should have reflections that inappropriate weaning due to the myth in the family and knowledge gap in the healthcare providers and leading to a lot of problems. If we actually can increase awareness of breastfeeding and support this mother with breastfeeding when the child is ill, this child might not end up severely wasted as in these situations. Next slide, please. If we actually switch over to my home country, we also have a lot of myth in we are actually considered a middle income country. G6PD deficiency is very common in my countries. For example, it says long-term baby born day 2 with jaundice. In my country, a lot of mothers may have very little cholesterol on day 2, but they were told to stop breastfeeding because this child has become jaundice. Many actually will go on to have God's milk because they feel that artificial artificial milk substitute actually will help with the jaundice. And this is actually incorrect knowledge among in the communities, as well as inadequate support. For example, this child will be admitted to our nurseries, but mother is not roomed in for breastfeeding. There's nobody to guide her how to actually breast direct latch while the child is under the photo light. Okay, next slide. So I think the next onward will be presented by Professor Angela Gusti.
Thank you, Sian. Next, please. So I'm next, please, Renzo. Next slide. Thank you. No, the previous one. We skipped one. Yeah, there is one in the middle. No. Okay. So it's not there, no problem. It was a slide about just to remind us what breast milk is. We all know, but I think sometimes, especially not only in low income or in low resource settings, also in high resource settings, we forget that breast milk provides the baby with perfectly calibrated, individual specific stem cells, prebiotics, probiotics, direct and indirect immunity, growth factors, neurobiological and epigenetic imprinting, as well as emotional, affective, and relational regulation. And also, of course, nourishment, the perfect nourishment. So my question is, how much would we pay for this product if it was industrially manufactured? So having stem cells for our babies or prebiotics or probiotics perfectly calibrated for this specific child. And so there are some slides missing, but it's not a problem. So my reflection is how is it so important to protect, promote, and support breastfeeding? All the presentation before me already said this, so I will not be long. This slide shows what is important during emergency, but also in low-resource settings. So shelter, water, food safety. And next slide, please. And also secure places where women can breastfeed in a private setting. Not all women like breastfeeding in public, and this is a difference in what we are trying to do in European countries is to promote breastfeeding in public, because it's a way to normalize breastfeeding again in the social representation. However, for some women, breastfeeding is a private act that requires a protected space away from the external view. And I thank Sian for this slide. It's from Malaysia, this experience. Next slide, please. Why it is so important to protect babies from the risk of formula feeding, because we have no control on what happens when the babies go out of the hospital after hospital discharge, and using formula and bottles can be really challenging because of the access to clean water, hygiene conditions, and safe preparation. And these lead to substantial health risk for the babies. Next slide, please. Here are some case studies from my personal experience. This one Ian presented already. This was a perfectly healthy baby in a refugee camp. This was a young Syrian mother, and she was given formula at the hospital discharge, labeled in Greek. And so this is an example of inappropriate donation of formula. And it happens in many countries. Formula, this was Formula 1, but we see also Formula 2, 3, etc. Next one, please. Sometimes formula is necessary, and in these cases, there is guidance provided by the Infant Feeding in Emergency Core Group. There is an operational guidance telling us what we should do, how we should manage the formula when it is necessary. And this is an example from, again, my personal experience. Formula should be managed by lactation experts, distributed according to strict guidance in a liquid form when it's possible, with an unbranded packaging, and given to the baby with cup feeding, not in a bottle. And the distribution is done on a daily basis to avoid uncontrolled distribution or oversupply. Next one, the one you see on the left is a midwife. I'm also a midwife, a colleague of mine called Alice, showing a mother how to feed the baby with a cup instead of the bottle. And on the right, you see an example of relactation. Lactation is possible in any settings. Any woman can relactate or do an inducted lactation, but it requires a strong motivation from the mother or the caregivers and a supportive environment. And also, most important, competent lactation support. And this is a grandmother lactating the baby after the mom died during childbirth. And what you see is formula milk, but the grandmother in this case, in a couple of weeks, started the milk supply and she could breastfeed her grandchild. And next one, please. This is an example of how difficult it can be to manage unsolicited baby food donations in any setting, low resource settings, emergency. This was a large shipment of baby food coming from Germany. And as you see, there are several problems in this donation because the products, they were inappropriate for the context because of the feeding method, but also not suitable for the intended age group. You see 4, so it's in German. In the refugee camp, they would not understand German, but they would understand number 4. That means starting from 4th month, which is inappropriate according to the WHO guidelines. And although we tried to stop distribution, 2 days later, the local municipality and the volunteers distributed all the content of the containers within the camp. And this raised, we had then a coordination meeting because it was not possible to just distribute donation in this uncontrolled way. And next one, please. And this is an example of what we are facing now in Italy, but also in France, in Spain, in Europe, in the Mediterranean Sea. I want to share this because this is just one of the many cases we witness in Italy, or as makeshift boats arrive from the North Africa after crossing the Mediterranean Sea. And during the journey, these people endure thirst, dehydration, hunger, fear, and rough seas. And those who survive and reach rescue teams are often exhausted and in critical condition. And just click, please, Lorenzo, for the next picture. Yeah. Yet, in this desperate situation, the only ones who appear well, radiant even, as you see, are the breastfed infants. Because throughout the entire travel, their mother have nourished them, kept them hydrated, and protected them. And what is the first thing that the rescue teams do when they bring them aboard? Instead of caring for the mother, ensuring she can continue to care for the baby and breastfeed the baby, they interrupt breastfeeding and provide formula. This is a problem. This is my personal frustration because we tried to implement correct procedure, but we still did not succeed. And this happened with the Navy, the Italian Navy, but also with NGOs that are working in the Mediterranean Sea. So next one, we skip this one, next one, okay. And this is the operational guidance I was talking about previously. You can download it from the Infant Feeding in Emergency website. And next one. Oh, okay, this is an example of our training with the emergency coordination teams and rescue teams. Next one. And we are almost at the end. I included this slide just to counterpoint the one about the boats crossing the Mediterranean Sea, to remind us that we too, we were once migrants living in Europe for America in search of a better life. And in 1895, the painter captured the natural presence of children of all ages in these paintings, breastfeeding or toddlers. Next one. Okay, you can see here we have on the left a breastfeeding mother and a pregnant mother, another breastfeeding mother, and a toddler sleeping in his mother's arms. And that's all for me. If you want more information, go to the Infant Feeding in Emergency websites. And thank you for the attention.
Professor Layone Thomas, Professor of Critical Care Nursing at Hill University and Director of the Clinical Research Development Program and Health Children's Hospital, Liverpool. She's Associate Editor of Nurse Critical Care and the Editorial Board Pediatric Critical Care Medicine and the Journal Parent and Enteral Nutrition. She's an intensive care nurse with 35 years and have experience in Australia and Q2. She's previously the nurse president of Europe Society Pediatric Intensive Care, SPNIC, and is currently elect chair of SPNIC Nutrition Section and deputy chair of Pediatric Critical Care Society Group of PICCS and member of ENRCCS Research Incubator. Thank you very much for the opportunity to listen to you. Please, that's up to you. Thank you.
Thank you. Sorry for having to go early. So I was asked to talk about learning from high-income settings and the guideline development process that we used in the European society. And I'll be less than 10 minutes. So this is the paper that we produced in 2020. So there was a large group of us in the European society, multidisciplinary. You can see that it was nurses, doctors, dietitians, and academics as well. So this was a systematic review and it led to 32 recommendations. But what we started with, which I think is important if this is what you want to do in low middle income country settings, we were all, well, there was a couple of people that, so except for one person really, we were clinicians, you know, so we all were clinical from our backgrounds. And what we wanted to start with was really what were the clinical questions that we were asked, what were the most important questions that often weren't answered in guidelines, maybe because they were too difficult, but these are the questions we were always asked. And so we started with them, clinical questions, and as I say, from that, we developed 32 recommendations. What's going on? Bear with me. Right, whoops, sorry. So there were 32. I'm not going to go through them all, and some of them really aren't applicable to low middle income settings. We looked at ECMO and all this sort of stuff. So the two that I think are the most relevant for low middle income settings are about nutritional assessment, which is important in any setting, and it's probably far more important in your setting so that you know what degree of malnutrition that your patients have, and that may determine lots of different things. And then, so this was a recommendation, which I think will be the same. The second one that I think out of the 32 that's probably the most important is the use of protocols, feeding protocols, because they really make a difference on outcomes. Now, there's no randomized control trials on this, but there was a large number. You can see the paper numbers there. Before and after studies, fairly big, particularly in high-risk populations. Now, for us, this often was the congenital heart group. So, except for one person, really, we were clinicians. Sorry. So, feeding protocols, I think, are really important, particularly in a high-risk population, because they really help people to actually initiate feeding, maintain it, and it really does make a difference. I'm going to go on. The other thing we did after we'd done, and I'll talk about the process in a second, is that you have to, just because you produce open access guidelines doesn't mean that clinicians, people in the clinical world can actually follow them or actually do follow them. You've got to make it easy for people to follow them. And so we then produced how do you implement these guidelines? Because it's all very well in some units to do that, but others are limited even in high income settings. And so there was quite a lot of things that we talked about. What equipment do you need? And this is probably really important for you in your setting because some of the equipment you won't have. And also what education do the staff need to be able to do that? And we defined that by role. So the dietitians needed certain things. You may not have many dietitians, but the nurses needed other things and the physicians needed something else. So we tailored it that way. But as I said, what we did was we started with 11 people, and we had a biostatistician, and we also used a librarian who did the search for us. So people were of their expertise, if you like. We didn't have clinicians doing other things and vice versa. So the review that we've published goes up until 2018. Oops. As I say, it's all described pretty well in the paper. What I would say is we broke into groups. Each of us had a PICO question. So there were 15 PICO questions based on the 15 clinical questions that we asked. The searches were done separately. They were put into a system called RYAN, which is free to access, which makes the screening much easier. And then they were graded according to the SIGN grading system, but you can use grades. So they were all graded, reviewed, extracted, and then the data was sent to the biostatistician. After that, we also, a lot of the stuff, as you can imagine, if you read the paper, was based on fairly low-level evidence. There weren't many randomized control trials. So actually then we made a statement, a best practice statement, if you like, and we voted on that. So we got consensus, and that was another key component of the thing, which you can see what we defined as consensus. And we used the agree reporting checklist for that. So this is all process. And just a couple of slides really around some of potentially important other components that you've all talked about today, really. But, you know, obviously in high income countries, as you would as well, we initiate early. I mean, you know, I think we wrote 24 to 48 hours, but actually in my unit, we initiate feeding within 6 hours of intubation. Well, admission, actually, normally they're intubated. Or we have access to blood gas monitors, which I realize low and middle income settings may not have. And as soon as the lactate's under 2, we would normally feed these patients, and the nurses will start that. And that's, we know that's beneficial in our setting. Whether it's beneficial in that speed in your setting is another matter, but certainly using a protocol and increasing gradually is really important in any of these patients. And of course, concern in some patients with surgical abdomens, any with severe organ dysfunction. And I mentioned gastric aspirates, a couple of people have mentioned. So I run a multi-center trial. We are 70% through. We have 3,300 children from 22 centers, and we're looking at not measuring gastric residual compared to gastric residual. I mean, this is a big reason that feeds are stopped in high-income countries, because people get a number, they think the number's accurate. The number is not accurate and it's unreliable. And that's been shown both in gastric ultrasound studies and in laboratory-based studies. So what you get out is not reliable. So if you're going to base anything on that, it's not really very helpful. Usually it results in feed stop.
Thank you.
And that's probably unhelpful in any of these patients. Oops. And of course, you need safe feeding practices. You need insertion of the tube properly. You need confirmation of the tube position. We use pH. Of course, that may or may not be possible with you. We try not to use x-rays. That's an absolutely last resort for us. And of course, tubing, safe tubing that you can't, so you don't get it mixed up with an intravenous line. So we have specific tubes for that. There isn't any benefit of continuous feeding over bolus feeding. And in fact, in a low and middle income setting, you need a feeding pump to feed continuously. So that's probably not helpful. And as there's no benefit, then I see no reason to do continuous feeding in the low income setting. There's also no evidence of post-pyloric feeding being advantageous over just gastric feeding. There are a couple of exceptions to that. If patient has severe burns, so they're, severe burns, they usually require repeated surgery every day, and that means that they end up fasting too much. And of course, patients with very severe burns have a very high metabolic demand. So we would always, the guidelines across Europe and the UK really are to put a nasojejunal tube down in the first hour, because this will be a real problem for these particular patients. But in other settings, that may not be the case. That's a specific example. As I say, there's no evidence suggesting the need to check gastric residuals, but we have no data in children. That's why the trial that I run is ongoing, and we should have completed data collection by October. So we don't know. We know in adults it's not helpful. We know in preterm babies it's probably not helpful. There's also a trial going on across 2 countries for 9,700 babies preterms. So we'll know the answer to that soon. And there's also no evidence to suggest the use of prokinetics. In terms of protein intake, the goal should be around 1.5 grams per kilo per day. And if you have poor protein intake, you've got worse outcomes, as you do with energy, because you need protein and energy to aid wound healing and immune function. But there isn't any particular benefit of elemental or peptide feeds over standard feeds. And we use just standard polymeric feeds here, which I guess is what feeds you use. But there may be some situations, but there is no evidence for that. Oops. And in terms of, I'm not a dietitian, but calorimetry we've looked at this multiple times. Even in high income settings, it's really very rarely used. We've just looked at this across Europe, and there's very few centers have an indirect calorimeter. And also, of course, they can only be used on bigger children, no air leaks, not high FO2. So there's some limitations of really who you could use it in. If you can, I guess that's great, but it's unlikely to be available in a low middle income setting. Whoops. Yes, thanks. Next slide. And then just finally, I think, there's a lot of questions that remain unanswered. We will be updating the review probably the end of this year, particularly when the gastric trial has finished, so that we'll have some evidence. We'll probably look at other things such as fibers in feeds. We don't know whether we should have fibers in feeds. There's no evidence for that. Well, we don't know. We need to look. Protein pump inhibitors has been a big issue. People asked should they use these. And also the other thing that's come up that people really want is information around feeding on renal replacement therapy. So probably we'll do an update. Well, we will do an update of the systematic review later in the year. But there's obviously other questions for you in terms of enteral feeds for malnourished children, the role of vitamin and trace element supplementation, and the composition of these feeds for malnourished children. And that was all I was going to say.